like. All right. Well, good morning, everybody. My name is Dr. James Economopoulos. You can call me Dr. I, and I am the TEXCHIP program coordinator. And TEXCHIP is a program where we prepare counseling students to work in integrated behavioral healthcare settings. We have a strong focus in our program, and really this is the direction we see our profession going, is to help prepare counseling students to work alongside medical providers. So we host trainings each semester, and this summer we've had a training last month on dialectical behavior therapy, and today we're having a training on bipolar related disorders. And so thank you all so much for joining us. And then I also have two outstanding helpers with me, Bethany Atkinson and also Dr. Sharon Mata. And let's congratulate Dr. Mata, who successfully defended her dissertation a couple of weeks ago. So congratulations. And then I'll go ahead and I'll let them introduce themselves a little bit more, and then we'll have the panelists introduce themselves, and then we can go ahead and get started.
I can start. Okay, so everyone, hi everyone. My name is Sharon Mata, or recently Dr. Mata. Is still new. Still feels a little bit weird. But all the students know me here, so yeah. Thank you so much for being here.
Okay. Hi, my name is Beth, doctoral candidate, and I am one of the graduate assistants here with TEXCHIP. And so thank you all so much for showing up. If you all have let myself or Sharon know that you won't be able to turn on your cameras for the training, that's totally okay. If you are able to turn on your cameras, please do so, because we want you to be able to interact with the panelists and so that they can see you when you're asking questions. And with that being said, we have, I'll let our trainer and panelists introduce themselves. And so Dr. Melendez, if you would like to start by introducing yourself.
Yeah, hi, good morning, everyone. My name is Oscar Melendez. I have a doctoral degree in clinical psychology. I am in Texas for about four years already. I came from Puerto Rico. My university, their framework is a neuroscience, but I have a background in psychoanalysis, but I don't know what else. I am in Edinburgh, Texas.
Yes, the Valley. Yes. Thank you so much for joining us, Dr. Melendez. And now our two panelists, Dr. Powell or Christy, if you would like to go first in introducing yourselves.
Go ahead. I'm Dr. Powell, and I work in private practice. I own and operate a group practice called Distinctive Counseling and Consulting in Corpus. I'm also an assistant professor with Delta State University and a postdoctoral fellow with Walden University. And I'm excited to be here to talk a little bit about the client that we'll be discussing and bipolar disorder from my perspective as a licensed professional counselor.
Good morning, everyone. This is Christy McVeigh, and I've been a nurse for over 30 years, ER background, a level 1 trauma center, and currently work as a chief of quality for a medical center in the San Antonio area. So excited to be here. I'm very much a patient advocate, and I'm always looking on how to bring in interdisciplinary providers so that we get a more holistic approach to care. So thank you for letting me be here.
Okay, thank you so much. All right, so I'm going to go ahead and share my screen, and I'll read out the case study, and then we'll answer the questions in the order that I emailed them to you already. So let me go ahead and do that. Okay, can everybody see my screen? Okay. All right, so today's case study, so we are doing our bipolar disorder training. So we're going to start off with A 25-year-old university graduate female patient presented to our outpatient clinic with symptoms of not completely remitting despite a 5-year-long psychiatric treatment. She complained of not being able to express herself and being incapable of social interaction with others, and she cried during the psychiatric interview. The patient had been administered different medication regimens for the last 3 years, and lagometrigine, 100 milligrams daily, and moclobemide, 600 milligrams daily, for the last 1.5 years. So despite being adherent to her medications, her symptoms of depression, lack of volition, thoughts of worthlessness, and anorexia persisted. She felt irritable and tense for no apparent reason from time to time, could not concentrate, felt an urge to move around restlessly, did not want to go to her house, and despite her family's objections, left the house to walk around at midnight. She said that during those periods, she had higher levels of self-confidence, got more sociable with strangers, was more talkative, felt more irritable, tense, and behaved aggressively, and burst into laughter, which was quite unusual for her. The patient reported that her symptoms first appeared during 6th grade after she began wearing glasses and was afraid of disgracing herself, felt unhappy, could not feel well even when something good happened, but her appetite and sleep were normal. Her symptoms increased when she left for college, and she only had a limited relationship with others. She felt more distressed in crowded places such as the classroom, dining hall, or library. She felt that she was worthless, had no motivation, and lacked energy, did not feel like leaving the bed all day long. Furthermore, she ate too much and felt the urge to move around restlessly. During this period, she presented to a psychiatrist and was diagnosed with depression and prescribed fluoxetine, 20 milligrams a day, and trifluperazine, 1 milligram daily. She did not completely adhere to her drugs. After 1 year, because her symptoms persisted, she presented to the psychiatric outpatient clinic of a university clinic. She was diagnosed with bipolar disorder type 2 and prescribed valproic acid, 1,000 milligrams a day, and sertraline, which is 50 milligrams daily. She was receiving these drugs for 1 year. However, she suffered from a dampening of her feelings and stopped her drugs because she thought that she did not need them anymore. At this time, another psychiatrist claimed that she was not suffering from bipolar disorder and that diagnosing this disorder was not easy, and if she was diagnosed with that disorder, it would not be a good decision to change her treatment. Therefore, she was confused and decided not to take any more drugs. After a short period, she was taken to the psychiatrist by her family members because she couldn't stop crying. The psychiatrist offered her lithium after he was told that she had been previously diagnosed with bipolar disorder. Furthermore, because of the nausea that she experienced, she stopped lithium. Yet after 5 months, she presented to another psychiatrist with symptoms of frequent crying, thoughts of worthlessness, depression, and anhedonia. She was prescribed lamotrigine and moclobemide, but she did not completely adhere to her treatment regimen, and her symptoms did not remit. The psychiatric evaluation of the patient revealed the following findings. She appeared to be of her biological age, was casually dressed, and her hair was disheveled, was overly restrained and shy, and could not easily express herself. She was alert and oriented, but did not have any issues with attention, memory, or perception. Her affect was depressed, and she had thoughts of worthlessness. No psychotic features were observed, and she had partial insight into her symptoms. No suicidal ideation was observed. All her routine laboratory investigation, including thyroid functions, was within the normal limits. Computerized brain tomography did not reveal any significant findings. On her psychometric evaluations, she received the following scores. They did the Hamilton Depression Rating Scale, 23 out of 51. Young Mania Rating Scale, 2 out of 60. Labowitz Social Phobia Anxiety Rating, 76 out of 96. And Avoidance Rating, 62 out of 96. Her MMPI results were interpreted as social withdrawal, low activity level, shy, and incompetent during interaction with others. During her psychiatric evaluation, she interestingly stated the following. There were times when I laughed without any reason, but I suppose that was not very healthy. It felt like some cream on spinach. The cream was fine, but it felt awkward because it was on spinach. All right, so with that long case study, here are questions. There we go. All right, so what do you think the clinical significance is of making the diagnosis of bipolar disorder in this patient? So Whoever wants to go first.
Everybody's shy. I thought you're gonna have a psychiatrist here. Would be great, right? But you don't have one psychiatrist, right? No, we cannot have that perspective. But I believe that thing happens too often. I believe every day, because in my opinion, it's an ego battle out there, and people, they don't communicate well, because counselors and psychologists, we know more the patient than psychiatrists. That is the truth. And we have more background to accurate make the diagnosis first. Well, not first, but to apport more information. Too often the psychiatrists see the patient like 15 minutes, and the system we have make them to make a diagnosis, and they quickly go there. I believe making a diagnosis, accurate diagnosis, help to guide the appropriate treatment. And it's like a snowball falling from the hill type of thing. And psychoeducation is crucial, because a lot of people, they don't understand why they feel. I believe 2 weeks ago or 3 weeks ago, I have a guy here crying because he cannot understand what he has. And it's probably the same case. But for me, it was very impacting seeing a male like me crying like a baby because he feels crazy. Because in the moment he's happy and the moment he's sad. And anybody around him, anybody like holds his energy. And I diagnosed him with bipolar. But I psychoed him first, and I sent him to a psychiatrist. And he was so softly through the system. But people, when they hear bipolar, they get scared too often.
I'm glad to hear that. You know, I look at this too from your perspective, Dr. Melendez, is that we need more information. Kind of was what I was thinking too, right? Like I think in terms of like answering this question as regarding the clinical significance is it can definitely be helpful for the patient to have an understanding of what's going on for them, right? But when I look at this case study and I think about, okay, they just had a psychiatric evaluation, which we know oftentimes is 15, 30 minutes, maybe an hour. There's not enough information that can really, I feel like, formulate this kind of a diagnosis. And I would like to have a psych eval done, a full psychological evaluation to really ensure that we have an accurate diagnosis so that we can help this patient moving forward. That was kind of my perspective in terms of clinical significance.
And this is Christy. I don't know so much from clinical significance, but from a nurse perspective, I'm always thinking about the patient. And so I think that there's still social stigma related to diagnoses such as this. And so I think it would be so imperative to make sure, just as both of you have previously said, that you're getting as much information and really doing an in-depth interview and putting all the pieces together to accurately diagnose if there's meds needed to make sure she's getting the correct medications. And I know just from a nurse perspective,
Did I lose sound?
No,
Okay.
Christy, I think we lost sound. We're not able to hear you anymore. Maybe it'll come back and she can answer that question again if you all wanted to go to another one.
Okay, I'll go ahead and move on to the second question. Also, if you could just, I mean, you could also let me know in the chat, Christy, or you can type out your answer if that's helpful as well. I think we might have lost her. Okay, so the second question is, This young woman has symptom onset as early as the 6th grade. Do you find that surprising for someone diagnosed with bipolar disorder?
Yeah, I thought this was interesting because, yes, right. So we know bipolar disorder is kind of going to be later in life, not at the age of, what, maybe 12, 13, which always kind of surprises me when I get patients even who come in with a bipolar diagnosis and they say they've had it since junior high. Going like, oh no, who did that? But I think when I looked at the onset of her symptoms, it was more characteristic of her social anxiety, right? Which, based on her responses to the assessment tools, it looks like she might meet criteria for social anxiety. And, when looking at bipolar disorder, there is sometimes that co-occurring diagnosis where they may have bipolar disorder, either and social anxiety, or they may have that kind of add-on of like with anxious features. So that's kind of how I interpreted that in terms of the onset of her symptoms. It was more related to the anxiety than I thought the bipolar disorder.
I believe like we used to think about these disorders and put every person in the same basket, and sometimes you can have the symptomatology of bipolar, but being it's so many things, because it's something can be inherited or can be blocked by the mechanisms you have. It's called DNA methylation. It's when your own system block the trace, the trace you're gonna have. That's why sometimes you see a grandfather bipolar, but the father is not, but the grandchild, yes. It's something that happened there. But I believe it's so many different types of ways you can have that symptoms, and we confuse everyone's. For example, I study psychology because I believe I can change people. I can help people to change speaking. But psychiatrists, they gave you a pill. They work organically. But thinking, for me, doesn't make any sense. Every bipolar needs a pill. I don't know if you get what I mean. Some it's the eldest battle about nurture and nature, and we don't know what is nature or is nurture. But we have evidence that can be nurtured too. If you put everyone in the same basket, maybe you are treating wrong. And going in that way, because I have friends with a chronic history of bipolar, and I see the kids, and you can see the traits in the kids. So very early, and I call it like a infantile hypomania or mania, but it's not classified. It's me. It's something I invent, but maybe in the future we're gonna see that, because we don't have studies in childs. But the thing is, we can see it. You can see it in the behavior, and too many times it's confused by ADHD or anxiety. So it's so many things we don't know. That the problem is we are in the 2024, and we still lacking of a lot of information. Recently, they discovered something. Is a DA is a transporter for dopamine, and they think this transporter has a lot of impact in the disorder, because in the bipolar, the dopamine neurotransmitter is so has a lot of to work or to do in the disorder. But I believe you can see the symptoms before. Maybe we need a protocol or something to make a watchful waiting until something happens.
Okay, thank you. I'm going to go ahead and move on to the third question. Hopefully Christy can log back on soon. Okay. What was your overall impression of this young woman, and how do you believe you can help her?
I'm here. I was able to get back on. Can you hear me?
Yes.
Y'all can? Okay,
Yes,
sorry, I had internet problems. So my overall impression of this lady, I think, looking at the case study, it appeared to me that she was quite a good historian. I mean, she gave as much information as I thought she could, knowing her medications, her dosages, talking about taking the meds, stopping taking the meds, giving reasons for stopping taking her meds. And so I felt she was able to effectively communicate. For me, from a nursing perspective, I think I would do more of a nursing assessment and maybe some more in-depth interviewing questions, trying to find out, going through her medications, which she's currently prescribed, is she taking them? Sometimes patients are prescribed meds. The providers assume they're taking them. I prescribed them, they're taking them, but maybe they've stopped, and then really delving into, why did you stop? Did you not like the way it made you feel? Is it cost prohibitive? And also trying to get a really good med rec on these people about over-the-counter meds, herbal meds, illicit substances, those types of things, because that all has to be looked at, I think, for her. So for me as a nurse, I would try to do a more in-depth interview and ask more probing questions so that I could develop a fuller picture of what was going on with this individual.
I because we lost you in the first question, and I don't know. I think it will be amazing to know your opinion in the second question about the onset in child, or because you are a nurse, you are more in this. You see more kids, like clinically in the hospital.
I did. We saw all, we from infant to geriatrics. For question number 2, what I would say about that is, it's interesting to me that maybe she was already feeling some type of stigma, because it appeared that her history was she started wearing glasses, and that's where things started to take a change in her life. And so I don't know if that was a self-imposed stigma she put on herself, or if it was something maybe family or friends. Bullying could have been an issue. I'm not a doctor, but I think that she could have had bipolar. I just find it interesting how she relates everything going back to when she started wearing glasses, which is unfortunate for her. And you did touch on, really evaluating these children carefully, because it could be things like ADHD. And then again, I worry about a child that feels so badly about wearing glasses, and where is that going to lead them? Are they going to go down a road of potential suicidal ideation? Or are they going to go down a road of substance abuse? Those are the things I would worry about in children that young that are feeling that. So, I mean, yeah, she could have had bipolar, but really doing that to drill down to accurately diagnose, I think, is ultimate for these patients.
In psychoanalysis, we talk about we have a metaphor about when you have something, right? You have this excess of energy, and that excess of energy gonna get out in multiple ways. And you can see people with speaking a lot, but this excess of energy gonna be in behaviors, or writing, or singing, or playing, in every scenarios. If you have it, but you're gonna see it. If I think it's organic. It's something about receptors or something not don't working properly, but you're born with that. Makes sense if you see it.
I guess I'll kind of talk a little bit about from a licensed counselor's perspective in terms of how I would maybe approach treatment. If this client came to me and said, you know, I've had the psychiatric evaluation and this is, you know, like Christy said, she's a good historian, so she would tell me all this information about her diagnosis. So one, I think I would start with psychoeducation, which I think Dr. Melendez mentioned earlier, right? Helping her understand, you know, the diagnosis of bipolar disorder, and what treatment might or could look like for her. I would also include a referral for a full psychological evaluation because I would want to get a better picture. And looking at it too from a holistic perspective, I would want to get to know more about this client in terms of what is she doing? Is she feeling a sense of purpose in her graduate program? How is she doing in her graduate program? Are there any needs there? I would also provide some psychoeducation in terms of medication consistency and compliance because although she has had treatment by a psychiatrist for the past 5 years, she hasn't necessarily been super compliant with her medication management. And so from my perspective, it would be hard for me to look at this as treatment resistance if she's not consistently taking her medication. So I would provide some assistance in helping her understand that it's important that she be consistent in that way, communicate with her psychiatrist, take their recommendations, and also understand that when we're looking at medication, unfortunately, it is very much of an experiment in terms of what's going to work for her. It's not going to be, oh, they're going to give you, and the first medication you take is going to work. So if she doesn't see improvements or she has negative side effects, that's part of the process. She needs to go back and communicate that with her psychiatrist so that they can maybe adjust her medications or add to her medications. Or take them away. And unfortunately, it just takes some time before she's going to find the right cocktail. And so I would help her understand that. And then I would also work on some emotional regulation exercises and some state change exercises to help her manage the anxiety that she's feeling and target that social anxiety while we're working on all these other things.
Yeah, I agree with Dr. Ginelle. I have the psychoeducation as a treatment, but I I always try to build up rapport, alliance. Is very important with this type of patients because when they it's the stigma. So people hear bipolar and they think they are like a something very. I find out myself telling me, mira, bipolar is nothing. So in my opinion, is you have a because I used to be a mechanic. I tell it's like I have a Toyota in my head. You have a Ferrari, and you can run speeds. I cannot, and they lower. I remember the guy. I was trying to let him to normalize a little bit. I created a list of athletes was being diagnosed with bipolar, and he was, I never know you. Psychiatry and DSM categorize that thing as a disease, but we have another models. What if it's not a disease, it's the way you are? And the guy, he start feeling better, and he's very, and another thing is like develop a comprehensive treatment, pharmacological and psychological. He doesn't want to be medicated, but I encourage him to go to the psychiatrist. Fortunately, I work with my wife and she's a psychiatrist. I talk to him and she treat him pharmacologically, and he's coming to therapy. But it's important. The rapport is very important because if you don't have alliance, they don't get adheration to the treatment.
And I just wanted to add, I know we were talking about medications and the importance of communicating with your providers. I mean, there's a multitude of meds out there. Maybe the first one or two that would be prescribed wouldn't be the right med, but it's that communication back and forth between the patient and the provider to find that right medication. And I think it is common. When you read back through the synopsis, at one point she was taking valproic acid and sertraline, and then she stopped it because she felt like she just didn't need it anymore. And I think, if I'm not mistaken, you see that a lot also with patients with schizophrenia. Once they start feeling better, then they're like, I don't need this medication anymore, and they just stop it. So I think really fostering that rapport with the patient, teaming up with them as partners so that they feel comfortable to confide in you. You know, I really feel better. Do I really need to take this medicine anymore? And having those conversations with them maybe would help her be more compliant in her medication regimen.
Thank you. Okay, so we'll move on to the fourth question. Per your perspective, how would you start the treatment for this young woman? I think y'all did touch on this already a little bit, but if there's anything else that you would like to add, that'd be great.
Just a few thoughts I had on that is as a nurse, really talking with the patient, getting more in-depth information and trying to identify gaps. What gaps does she have? Are there some social needs there? Is there some help maybe with prescription costs? Just really trying to identify from an interdisciplinary approach, what are some gaps that as a nurse you could identify and then share with the interdisciplinary team to get a well-rounded treatment plan for her.
Yeah, I think starting the treatment is important to have the medical evaluation and psychotherapy, CBT, interpersonal and social reading therapy, lifestyle modifications, so encourage healthy diets, good sleeping patterns. I was working with a female, and she, in the moment I was telling her about the interpersonal social reading therapy, and I start psychoeducating her about the treatment and the importance to make like schedule of the patterns of sleep. And she opened the eyes very big and she told me, I did that, yo. How come? I find out every day at 3 p.m. I feel the same way. Yo, it's very interesting. So she by herself noticed she have this time frame of manic episodes, and we start working around this pattern. And support system. I bring to therapy the collateral people, the husband, the family, when it's appropriate, and I think she's gonna have benefits of the patient. I include the collateral. I see a question in the chat about medications, and in Puerto Rico, I used to work in a FEP program. This FEP program, I don't know how do you call it here? I believe it's called Navigates. It's a program, federal program to work with schizophrenia, pre-psychotic, and this cluster of disorders. And in this program, I have the opportunity to work hand by hand with the psychiatrist, and I can learn by them. That is the purpose. They learn psychology, and we learn about medication with them. And I see that thing, and they don't like when we suggest medications. That for them is like the worst thing, because first we don't know about for prescribing. You need to have competences in biology, and they get offended when somebody that without training tell them to do what to do, right? And I always go low. Mira, the patient is complaining about this medication, blah, blah, blah. Check out what all options he has. But I never tell them what to do or not to do, because they get mad because we are invading their role. that's why I don't answer the question 7, because that is not my boundaries of competences.
I agree completely, right? We have to be so careful when we talk about medication management that we're not advising the client on anything specific to adjusting or changing their medications. But I do think there's room for us as counselors to help our clients feel empowered to be the expert in their own lives and advocate for their needs with their psychiatrist. And so I might do some role playing of what that would look like to help the client practice sharing that information with their psychiatrist. And also not being afraid to get a second opinion from another psychiatrist. If their psychiatrist isn't listening to them or isn't giving them the appropriate amount of time, you know, that can be very, very hard, especially like in our community in Corpus Christi, where there's such a shortage of psychiatrists. But I do think we are in a space now with telehealth booming, being able to have options to log in on a telehealth meeting with a psychiatrist who may not be located in the Corpus Christi area, but would be able to meet with them. And so always knowing that they have that ability as well, because they are the patient and their needs are important. So I think I would approach it from that perspective for to answer Tosin's question and to kind of build off of what you were talking about, Dr. Melendez.
Yeah, and it's another thing too. We need to remember they have another board. It's not our board. They have other rules. And when we start talking about medication and stuff like that, we can be lawsuit in some scenarios because that is happening right now. As a psychologist, she start telling the patient, the psychiatrist is giving him the wrong medication, and he's doing harm. And now it's a problem in court by that thing. That we need también to save our to play safe.
Stay in our lane.
Play safe, because you never know what thing gonna fall over you.
Awesome, thank y'all. So we'll go ahead and move on to question 5. So how would integrated healthcare be beneficial for this young woman's case?
I think it would be extremely helpful. Just even right now, having this panel discussion with Dr. Melendez and his expertise and background, and Christy and her expertise and background, and me coming in from a licensed counselor approach, right, which is like a wellness model, holistic model. I think we're already seeing that we've, you know, been able to look at this from various perspectives, and so having the psychiatrist being a part of this team, like Dr. Melendez mentioned, having a psychiatrist here today would be wonderful. And then also a primary care physician, where we would really be looking at, is there any physical issues, which we did see in the case study, right? That was helpful information to know that there weren't any underlying physical issues that would be contributing to the symptoms that she's presenting with. But I think it just gives us more information and allows us to provide that mental health care, the medication management, and the full a full psychological evaluation to really be able to understand and know this client thoroughly, and not just bringing them in and seeing a snapshot of what's going on in one perspective. I think that's how integrated behavioral health would be helpful from my perspective.
I agree with that. I'm always trying to think about all the players. So definitely psychology, psychiatry, primary care, social work. Sometimes they know those community resources, pharmacy. So maybe this individual is getting medications from her primary care. She's getting them from her psychologist. And so sometimes if you have a pharmacist that you can involve, they can look for interactions and those types of things. And a lot of times, they can make those recommendations for changes to medication regimen. So that's always, I think, a really helpful discipline to have. I think about peer support programs. And I know this write-up did not really talk, this history we had didn't really talk about any substance abuse issues or really suicidal ideation. But again, being mindful of that and really trying to assess for that, because those are things that people may not be willing to share unless we really do an in-depth interview with them, to make sure that we're hitting all the points in order to provide the best care for them.
Yeah, it's like a when you have a good team, it's always better for a patient. But I believe the students, they are starting this career now. They need to start building bridges and connections, because in my practice, I have a child psychiatrist, I have a nurse psychiatrist, I refer the patients, and they already know how I work, and we work together, and we are in the same page. We don't have this fight about medication. Don't do that, don't do that. I believe, but when everybody is advocating for a patient, it's good. Work fine.
Okay, I can move on to question 6. So what suggestions do you have for novice helping professionals to be mindful of when working with patients with bipolar disorder?
I feel like we've-
Education.
Go ahead. No, you go ahead.
Education, understand the complexities, right, of the conditions. Empathy is super important, and for me it helps because I was forming in psychoanalysis, and psychoanalysis practice a lot the active listening, and we don't speak too much. We hear, try to understand. That is crucial, because think about it. When the patient came to you with this problem, they want to be understood. They don't want you to start shooting diagnosis, and that they don't used to. I have a couple ones, they want the label, but most of them, they don't want the label. Communication, and every person has a new history. So not all the patients are the same. Can have the same symptoms, but the root is all different. Mentoring and support. Involvement with the family, like I said before, is good. Brings the family or the collaterals to therapy. That work for me. I only have one bad experience with a guy, but he was doing good, and respect the boundaries of competences, not invading the roles. I believe if you achieve how to communicate patients' claims or something, helps a lot.
Yeah, I second everything you just shared. And I think, again, from a licensed counselor's perspective, is knowing that you also can collaborate with a psychiatrist. I love getting on the phone with psychiatrists here in the community, to consult, to kind of share what I'm seeing, and hear a little bit about how they're doing in terms of medication management. So knowing that don't be afraid to do that or intimidated to do that. It actually just helps to ensure continuity of care for your clients. And my experience has been, at least here in the local community, psychiatrists are willing to do that. Might be hard to get our schedules to get together, but won't take long to get on the phone with them. I think the other thing is knowing that with working with patients with bipolar disorder is to not just see them as that label, and to look at them as the whole person, and that we want to treat the symptoms right? And we want to help validate, affirm, and normalize that. I love what Dr. Melendez shared about, like, here's a list of athletes with this diagnosis, and how can you still function and you know, move forward with this diagnosis and be okay. What does that look like for you? And so I think those are just some of the suggestions I have for maybe newer helping professionals. And don't be afraid of it, right? I think we see that diagnosis and we go, oh, I don't know what to do with that. But I hope that I was able to, like, share from, you know, a treatment provider's perspective as a counselor, is that you can absolutely provide assistance to a client with that diagnosis when you look at them as a whole human being.
From my perspective, Dr. Melendez, absolutely active listening to understand, not listening to try to have a prepared response. So asking questions, you know, as your client is speaking, getting in there, following up, doing a little bit deeper dive on some of the responses, history they're giving you, so that you have a better understanding to clarify. I think another thing is always being mindful of your personal biases. We want to make sure we're being non-judgmental. That is so important. And I'm going to tell you, these people can pick up on your body language or your inferences in your voice. And so it's great if you can assess yourself and know what those biases are. It's okay to have bias. It's just knowing that, and then really, you know, working to be that non-judgmental person. And for everyone, know your resources. Never be afraid to reach out. Network, that is so invaluable. I mean, it may be a student, someone you went to school with, it may be a professor you had, it may be your own personal providers that can give you resources to go to. Social workers have a lot of resources they can share, but don't work in a silo. Don't do this by yourself. The more eyes you can have, giving a holistic approach. I work with veterans, and so I always tell people, where is the veteran in the center of the conversation? Because if you always put your client first, if you put them in the center of everything you do, and you're doing it for the benefit of the patient, you can't go wrong. You're going to be able to provide that safe, quality care for them. And the last thing I would tell you is, just don't cookie cutter. Treat everyone as an individual. They may have cookie cutter diagnoses, but we're all people. And so treating everybody as one individual, and learning those nuances, and really just listening to them. So those are my words of wisdom I would give you.
Yeah, listening is very important. And I have so many anecdotes. I remember a patient one day in the program, in the FEP program. The patient was talking with me, with one of my peers, and when he went to the clinic, he expect to see a male, but was a she, and he doesn't want to share his things with her, and she convinced him to talk, and she started listening and understand his pain, and he told her at the end, you know what? I was about to suicide today, because I don't find the help I want, because I came here and you were a female. And I was, thank you for convincing me to stay, because I was thinking to go out to suicide. And in that moment I realized, yeah, we don't know. We faces, come on, you have this land here. We faces we see, but hearts not. It's a metaphor we said, caras vemos, pero corazones no sabemos.
Thank you so much for sharing y'all's experiences and your suggestions. I know we kind of alluded to question 7 already, and y'all have disclosed, like, you know, stay in our lanes. We want to make sure that medical providers are giving those or prescribing the medication. And I'm also wondering if maybe there are if there's any other information y'all would like to know about the client/patient when moving forward with treatment, whether that is medication, whether that is any other information that you believe is pertinent to the case.
I think just to kind of reiterate, right, like importance of understanding medication compliance and communicating with her provider. I think that would be important when I'm looking at medication management as one of her treatment goals. But more, I would like to know a little bit more about like what is going well for her right now? Where are her strengths? To build off of that. And I would also like to know how she's doing in her relationships. So like who does she live with? Does she have peers or colleagues? She's struggling with social anxiety, but I would wonder, does she, you know, who does she have that she can trust? I think that would be a little bit more. And then I know Christy talked about this earlier, but looking at suicidality as well, since that is something that can come up with patients diagnosed with bipolar disorder, I would assess for that at the start of treatment and do some safety planning, and then go back into safety planning and referencing that throughout treatment to ensure that she's staying well and is going to stay alive while she's in treatment. That's important because it can feel very, I think, disheartening with someone with bipolar disorder or any mental health treatment where they're struggling to feel better and they feel like they're engaging in treatment and aren't seeing the results that they want. Suicidality can definitely come up. So, yeah.
And I would just add on that, absolutely, I think you would need to assess her safety. Where is she living? Does she have housing? That's huge. And again, that suicide assessment is critical. And then I think it's also important to know what really talking with her and finding out what are her treatment goals. Maybe our treatment goals aren't really her treatment goals, or maybe she's oppositional to one of the treatment goals, and being able to have those discussions and working that treatment plan around what her goals are.
Thank you all so much. I noticed that we had a question in the chat and that Dr. Powell did answer it. But I was just wondering, let me see. I'm trying to get the chat back up so I can ask it out loud for everybody to make sure that everybody knows about the questions. So we had a student ask if there are any tips on how to encourage clients to agree to release of records between healthcare providers. And Dr. Powell, if you'd like to share your response.
Yeah, so I would just in psychoeducation talk a little bit about how it can be effective for the client that I communicate with their providers to ensure continuity of care, consistency, and effectiveness all around. Historically, when I've done this with clients, they're ready to do it. I've not experienced resistance. They're like excited that we care about them to take time outside of the session to consult with their other providers. They're motivated to experience relief from their symptoms, and they feel like it would be beneficial for me to know what's going on with their psychiatric care or even with their primary care physician. And I just say, I'm going to send this to you in your portal, log in, sign it. And once I get that, then I can move forward with communicating with them.
Okay, thank you all so much for participating in our panel discussion. Those are all of our questions. Dr. I'm wondering if any students have a couple of questions, if maybe our panel, and also for the panelists, if y'all are open to answering one or two more questions, because we do set aside till 10:15, but we do understand if you all have to go, that's completely okay too. So I was just wondering if that's an option for the next like 5 minutes.
Yeah, we can offer, I think it's okay. If panelists can't stay, that's understandable. But yeah, we're willing to answer questions now. that students may have. Anybody have any questions for our panelists?
Yeah, I guess I have one. I guess with this population specifically, how important is it to be aware of, and I guess to psychoeducate on how substance use, might impact, I guess, like the symptomology of like this diagnosis, even with something just like casual drinking too.
I think that's a good point that you bring up, Trevor. I would first, ask about what her substance use looks like. She's a graduate student, so is alcohol a factor for her? Or even maybe something that I commonly see might be like cannabis use, right? And so I would kind of assess for that in that first intake appointment. It's part of our standard intake questionnaire as well. So I'll usually reference that there and see what the answer was. Talk about how alcohol use may impact the efficacy of her medications, and provide some psychoeducation on how alcohol can cause or increase symptoms of anxiety, because there is that kind of withdrawal period the following day. And then the same thing with cannabis use, what I typically, because that is very commonly used, especially in that age group, I would talk about how basically like putting a Band-Aid on something that needs stitches. She might experience some like, temporary relief, but it's not really going to provide any long-term relief, and it can alter the chemicals in her brain, and we don't know exactly how that could impact her and kind of exacerbate her symptoms.
And I would just add, if you're seeing a client that maybe in a clinic setting where they see a nurse first, please always be aware that patients will commonly tell a nurse one thing and their provider something else. And I know nurses do assess for illicit medications. We do assess for all medications. We'll ask, do you smoke? And so it is common that they will deny it all to the nurse, and then the provider comes in and it's a different story. So if you're looking through nurses' documentation and you see it, don't just say, well, the nurse already asked and it's no. Go ahead and ask the patient again, because patients feel different comfort levels with different providers. And so it's always a safe bet to follow up on those, even though it may have already been assessed. Just follow up and see what the response is.
I think that's such a good point too, because oftentimes when they fill out that standard intake questionnaire, they don't feel comfortable putting something in writing, but they will verbally discuss it with you in the session. So that's like a really good point, is not to just like take that at face value, but to like review that with the client and make sure, depending on how you do your intakes. In my practice, that's how we do our intakes. They fill out the form and then we go into the session and review it with them. But that's such a good point, because they might not feel comfortable to disclose it in writing, but they will disclose it once they see that this is a safe space and you're here to help them.
Can I
Cool,
say
thank
something?
you.
I believe I used to have a patient, no, wasn't alcohol or drugs, but I came from Puerto Rico. In Puerto Rico, carrying a knife is illegal. You cannot carry a knife. And this patient, he was carrying a knife everywhere, and he was bipolar, very impulsive, very aggressive with a knife. And I don't want him with a knife. And he came to my therapy because he came out from jail after 17 years. And I was trying to reduce risks. And I helped him in therapy to get rid from the knife. But I never mentioned the knife. I throw crumbles, and I tell him, hey, I'm worried if with this intensity you have, you get in a trouble and the police came, see you with the knife, and you finish in jail again, something like that. And one day he told me, I don't carry the knife anymore. I stopped paying attention to the knife, and he did by himself. I tell you that because sometimes if we pay a lot of attention to the substance, they feel judged, and that you put a barrier in the therapy. And maybe when you address the person, the symptoms remit the substance they use. Happens.
Can I say something, Bethany?
Yes.
It's Trisha. We were talking about like medications and stuff like that, and I think I mentioned about it being like our out of scope, like what is our scope of what we can do. And so when it does come to medications, and clients start talking about different medications they're on, and if they're just, we can't really give them like any advice on medication at all or talk about medication because we don't know that, that's out of our scope. So the best thing that we do is, well, I usually do, if they're having problems with their medication, it's not working for them and they're feeling frustrated, I always kind of refer them back to their doctor because I'm not the expert in medicine. So is that the correct thing to do?
Yes, empowering them to be able to communicate how their medication is affecting them, right? And so I think it's important to understand that while we're staying in our lane, it doesn't mean the conversation is off topic and we don't address it at all. It's rather that we invite the client to share what it's like for them with their medication and encourage them, empower them to communicate with their primary care doctor who's prescribing them or their psychiatrist who's prescribing them. And it's also a really good space too to even say, hey, can I get a release of information to, communicate some of the stuff that you're disclosing and what I'm seeing too, because I'm not seeing that your symptoms are, improving. And I can share that with your prescribing physician. So I definitely think it's okay to talk about. What we want to avoid is saying, oh yeah, you shouldn't be on that medication. Why don't you try Prozac instead? Right? That would be off limits because that is not in our area of expertise as licensed counselors.
Thank you.
Okay, I think that's it for questions.
All right. Thank you all so much for being here and serving us with all your feedback and your wonderful answers to our questions, and for taking the time to review this case study and really just providing really great insight for us. So we really want to thank all the panelists who came today and thank the students for asking questions. And we're going to go ahead and take a 15-minute break now. And then when we come back, it'll be, around 11:27. I'm sorry, 10:27. And then we'll go ahead and continue with the rest of our training. So we'll have Dr. Melendez train us today. But I want to thank again Dr. Powell and Christy. Thank you all so much for joining us. You all are welcome, of course, to stay. But otherwise, hope that you'll have a great rest of your weekend, and we'll be back in 15 minutes.
Thank you so much. You guys have a great day.
Thank
Bye.
you.
Mhm.
Thank you.
Okay, welcome back, everybody. We're going to give Dr. Melendez as much time as he needs now. And again, as a reminder, please remember to keep your cameras on and be present. Of course, if you need to move around, you can shut off your camera. Don't just have your camera off, though, for more than like 30 minutes. So we understand that if you need to take breaks and stuff, that can happen. All right, well, I believe, Dr. Melendez, you should have screen sharing privileges now. So whenever you're ready to go ahead and get started.
Okay. Aquí. Ajá. Pero lo puse pequeño. We are there, right?
Yes, we can see it.
Tengo aquí un montón de pantallas abiertas. Estoy tratando de... No me deja ponerla... Es que los veo ustedes en el medio. Bueno, los puse para aquí al ladito. Bueno, good afternoon, everyone. Or, yeah. Good morning. My name is Oscar Meléndez. Ves que ahora tengo todo esto en el medio y no puedo verlo a ustedes. Like I said before, I hold a doctoral degree in clinical psychology from Ponce, Puerto Rico. And this university have a framework in neuroscience. And prior to pursuing that career, I was a mechanic and a business owner. I also have a background in psychoanalytic studies, but not the American way, because I don't know if you know much about psychoanalysis, but psychoanalysis is different in Europe. And in my leisure time, I used to bodyboarding in Puerto Rico, but here in Texas, we don't have too much places to do, modifying cars and stuff, and spend time with my daughter. My decision to study psychology stemmed from the lifelong impulse to observe and fix things and environments. I used to in my practice I used to work with schema therapy. I don't know if you are familiar with that model. People think it's psychoanalytic, but it's more Piagetan type of thing. And I encourage people to use that because help us to understand us better. And these traits about fixing things is in the schema when I did it for myself. I like to help. I don't know how many of you speak Spanish. It's so some students speak Spanish. I like to share with you because maybe you notice my native language is Spanish and I struggle a lot with the English because I think in Spanish and I need to translate in my head to tell the things. And I find out that thing in media, and for me was awesome because not helps me to understand how, because I don't consider myself bilingual, because bilingual is I believe is even beyond. I can speak English with my deficits, but I'm not totally bilingual. And I don't know if you like to take a look of that and read it and check it out if you can, how many of you can be able to understand. And give me your feedback about.
It's very fun. I like it.
I have another more there, but and I share that thing with my colleagues because I have a lot of colleagues from Puerto Rico here, and sometimes we need to understand that things because in bipolar you can see stuff of that because people struggle to say things and they level up the communication and in psychology we have something called weird samples. I don't know if you know what is weird, but it's because psychology was based on Caucasians. In Puerto Rico, we call it the perfect people from Minnesota because they are Caucasians, white from Minnesota. They are perfect, but Hispanic, we are not like them. We are different. And we tend to have other behaviors that can be misunderstood or misinterpreted, like some traits. I used to have I had a patient one day and he came to me with a autism spectrum disorder diagnostic. When I started working with the kid, I was so surprised because he wasn't. He was black from Chicago, and he was living here in Texas. He's a little bit shy, but nothing about autism. But that different culture, the therapists who see him doesn't understand that he is black, and black people, they behave different sometimes, or Cubans or Dominicans. I have another things there.
Did you know that if you spell socks really fast, it sounds like you're speaking in Spanish? Socks? Yes. Eso sí que es.
Eso sí que es. But that is my office. It's the place I am today. We have this private clinic. We call it Our Psyche. We provide here psychology and psychiatry services and TMS, transcranial magnetism stimulation. And you have maybe a better idea, because when I have patients like that, like bipolar, for me it's good because we have a psychiatrist on board and we can provide better, I believe, better service. I was being here in McAllen for 4 years, I believe. And during this time, I had the privilege to work with families. So when I start working here, it's a question a lot of people have. I believe maybe a couple of you have the same thing too, because for me, it doesn't make sense when a psychologist say, no, I only work with couples. I only work with kids. I believe we are trying to work with whatever. And I believe we are the ones that put limits on our duty. For example, when I learned from life, I'm 49, but when you find in the life something that you struggle, maybe something you need to challenge, right? And for me, it doesn't make sense when a therapist said, no, I don't want to work with females. Why not? If she speak or she can hear you, I don't see any problem with that. But that's why I enjoy here. I have a very variety of population, and I learn a lot here. And in this presentation, we were covering the symptoms, diagnosis, treatments of bipolar. Maybe I aim, or I want you to get a better understanding of bipolar, and how people suffer from that. I try to cover all the bases, but sometimes, too many times, we cannot cover everything, right? And if we wanna define the bipolar disorder, describe the types, discuss the cause and risk factors, explain the mood episodes, and review treatment options. We're gonna explore some daily life living situations, address stigma, misconceptions, discussing. I bring some cases example to make some dynamic between us. How many students we have here?
I believe it's 12.
Okay. And I create that thing. I already told you a little bit about me, but I wish each one of you maybe answer that question and choose the next one to know each other a little bit more. But what is your name? Your name, I can see your name in the thing. But what is your favorite movie, your hobby, and what is your interest in psychology? Why you came to that discipline?
I'll go first. My name's Trisha. My favorite movie is A League of Their Own. Do I have a hobby? I don't know if I have a hobby.
Oh.
I gotta think about that right now. And then why are you interested in psychology? Well, I had an undergrad in psychology. I think when I first went in it, I was just interested in learning about people's behaviors. And I thought that was just really interesting. And then I decided I wanted to go into counseling because I could hopefully learn more skills of helping people. And like collaborating and change and stuff like that. So yeah, I think that's why I'm interested in this. I love so far I love what I do. So that just kind of like validates I know I'm doing what I should be doing. So
That makes it
yeah.
a hobby.
Yeah.
Because you're
So
enjoying.
hobby,
No.
I do like listening to podcasts.
I meant if you enjoy your work, that makes your work a hobby.
Yeah, that's true. That is true. It's a good hobby. And hopefully it pays really good when I graduate. No, no. It's an incentive. It's definitely an incentive. But yeah, that's it. That's who I am.
Okay. Who's next?
I can go next. My name is Tosin. My favorite movie changes every year, but Baby's Day Out seems to be still there every single year. My favorite what's my hobby? I enjoy writing. I also enjoy being outdoors, going for walks, having picnics, and my interest in psychology stems from my passion and belief that it's my purpose to help people. And I've just always been intrigued by the way our minds work and the way that our past influences our current worldview. And yeah, I'm just really passionate about helping people figure out all the knots that are going on in their brain and helping them unravel that and live better lives.
Thank you. Who's next?
I can go next. So, hi, my name is Price. Favorite movie? Probably The Godfather. Favorite, just a hobby, I play Pokemon Go. And then interest in psychology. Well, I also did mine in undergrad, but I got into that really just honestly by chance. I sat in on a lecture and I found that I really enjoyed it. And from there, I just grew more and more like engaged and fascinated in the ways that, our brains work and how the mind processes things and all of that stuff and how we react to the world around us. And that's kind of led me to where I am today.
I can go next. Hi. My name is Destiny. My favorite movies, I like all Harry Potter movies, so I guess it's a couple of them. My favorite hobby, I just like to relax in my free time. I don't really get a lot of free time because I have kids and I'm a grad student. So when I do have free time, I just like to watch my shows or like play the game or sleep or eat something nice. Interested in psychology. It was my undergrad as well, but the more I got into it, the more I grew curious at how individual people's mind worked instead of just a collective, how the factors of your life and your background, how everything just, becomes like who you are. So yeah, so I like my job. So I get to learn about a lot of different people.
Okay, I'll go next. I'm Jessica Blakesley. I'm joined by Boots, my dog, who can't seem to get off my lap this morning. I don't really have a favorite movie. I'm not a big movie watcher, but I do love The Office, the TV show. My hobbies currently include CrossFit, and I love baking, so they kind of balance each other out. And I'm interested in, my undergrad is also in psychology. I was actually previously going to school to be a dentist, and I realized that I just wasn't passionate about that. But I love people and they interest me, and this is a way that I can connect with others.
I'll go. Hi, I'm Nora. My favorite movie is Miss Congeniality. My hobby is I like to read books in my free time. And then my interest in psychology really stems from I like listening to other people. And this is a field where you do a lot of listening.
I can go next. I'm not able to turn my camera on right now, but my name is Faith.
My favorite movie is Princess and the Frog. One of my hobbies right now has been scrapbooking, and my interest in psychology really started back in high school when I took it dual credit. That was the first big interest I had in it, and it continued through undergrad. And obviously, now I enjoy listening and helping others.
I can go next. My name is Abby. My favorite movies are the Harry Potter movies as well. My favorite one's probably Prisoner of Azkaban. My hobby, I read a lot as well. And I'm interested in psychology because that honestly just kind of came natural to me. I grew up just always loving to listen to people, and my undergrad was in psychology, and so it just felt natural to go into graduate school with a counseling degree and making a career out of it.
I can go next. So my name is Dana. My favorite movie is Sixth Sense. Sixth Sense, yes. I enjoy traveling, and when I was very young, I had the opportunity to shadow a psychiatrist. He was my uncle in Mexico. I grew up in Mexico. And I found like a really powerful experience I had that I had the first contact in the mental health field, and since then growth inside of my head a deep interest about human behavior, neuroscience. I do want to know how the brain works, and yes, I think that is the reason why I love this field. I found it very interesting. A whole universe inside in our heads.
I can
Hello.
go next. Oh, go ahead, Clarissa.
Okay. So my name's Clarissa. My favorite movie, I don't really watch movies, but I like scary movies when they do come out. What is my hobby? I go to the gym, that's my relaxation, or I go take walks on the trail. I guess what you could say, like, what are your like interested in psychology? It was my undergrad, and then I was able to get like job positions where worked with people in the community. I used to work with CPS, so you see a lot of, a lot of removals and stuff like that. I worked in the investigations department. And so it just was very like putting a band-aid on like problems that you could see like had occurred when they were younger and then they became parents. And then it's just the cycle that you see. And so I kind of wanted to get more involved and stuff. So I always like that idea of helping people and trying to figure out how they can improve their lives through those experiences.
I'll go. My name's Hannah. My favorite movie is probably Empire Strikes Back. I'm a huge Star Wars fan, so anybody who knows me knows that. Some hobbies that I have, like reading, building Legos, sewing. And then I became interested in psychology, I think from personal experience, being in therapy myself, and then kind of growing up, I've always wanted to be in the service field and helping people. And I've kind of just, my undergrad was also in psychology, and learning more just excited me about the field, and definitely being in this program has done that too.
I'm Aaron. One of my favorite movies is Joe versus the Volcano. One of my favorite hobbies is canine search and rescue. And I'm pursuing this degree because I've seen people in my life be really benefited from counseling and mental health care. And I want to be able to help people, as many people as I can, with those same benefits.
I'll go next. My name is Trevor. My favorite movie is Donnie Darko. hobbies are I like exercising, hiking, mountain biking, even though we don't have any mountains here. Like reading too. I'm interested in psychology because I like helping people. And I think it's a field that has like a very high ceiling, or if at all, so you can always kind of continue to get better and like work on it. That and just it's very individualized, like per client, and I really like that. And I think with that, that'll help it kind of stay fresh, for like the whole my whole tenure as a counselor. So yeah.
Missing one.
Oh, my name's Phoebe. Um, my favorite movie is probably Young Frankenstein. Um, let's see. I've always been interested in psychology. I've always been kind of a nosy person, a curious person. And then I think I also wanted to work in this field because, I've been helped by counseling and I would love to be able to do that for others.
My name is Angie. My favorite movie is probably any Studio Ghibli movie, probably like Ponyo or Spirited Away. I have a couple hobbies. I'm a power lifter, so I like to lift heavy things. I like to dance as well, any kind of dancing really. And I also like to bake. I got interested in psychology from my undergrad. So I'm currently getting my master's in clinical psychology, but I'm really interested in psychotherapy. So I want to be an LPC and kind of learn a lot more about underserved communities, really. I want to focus on neurodivergence and also bilingual individuals as well. Because I actually come from McAllen, Texas, so from the Valley as well. So I kind of understand how there's a big gap there in mental health. It's gotten a lot better, but it's
Yeah. We already, all right. Frankenstein is an allegory, right?
Yeah.
Yeah.
I love the movie was like a parody, but I love the book too, in for the more serious
It's a good
points.
story.
Yeah.
And you are a very diverse group with a lot of talents, and for sure you're gonna do a lot of help out there. And most of you like the things you do. That is the main thing, right? Enjoying your trip, because sometimes you're gonna cry a lot. And now we know each other a little bit more. Vamos para lo que venimos. I'm not missing anyone, right? Because the other two is the professor, right? I don't know if I caught someone.
I don't mind going if y'all.
Okay, no, because okay.
All right. So yes, students know me as Dr. I, but people call me Jimmy. I was Jimmy first. My favorite movie is probably Bloodsport. I've watched it like a million times. So if I'm honest with myself, that's probably my favorite movie with Jean-Claude Van Damme. So my hobbies, I really like to study theology. I like to read the Bible. I'm a Christian. I'm Greek Orthodox Christian. That's probably, something that I spend a lot of time doing. And what am I interested in, or what got me interested in psychology? So probably related to my faith and values. I know the way I understand psychology, so I'm going to teach y'all some Greek here real quick. So psyche means soul, right? And ology or ology is like the knowledge of something. So it's like the knowledge or study of the soul. And I think that's sort of what led me to want to be a counselor, is what really helps heal people's souls, so healing is a big part of my interest as well, like really what helps people heal from trauma and how can we help people overcome their challenges. That's why I like Bloodsport. I like movies about like overcoming adversity and challenges, and it's a martial arts movie, but I'd say it all kind of relates and kind of reveals a little bit about who I am. So thank you.
Now, thank you to you, but now it's Bethany because
Okay,
Dr. Mata.
I can go first since Dr. I went. My name is Beth. I mean, my name is Bethany, but I go by Beth, Bethany, whichever is fine. My favorite movie is probably the Hobbit trilogy. My hobby is exercise, so if that's in the gym or running, I'm doing that all the time these days. Why am I interested in psychology? It was an accident. I was a fashion major. I was told that you can't do anything with a psych degree, but I was always super interested in it. I took one class, fell in love with it, and decided I was gonna do that instead. And I had my master's in counseling psychology, and then just kept continuing and trying to finish this PhD. So.
Okay, so my name is Sharon. My favorite movie is probably Shrek, the very first one. And very importantly, it has to be the one in Spanish. I just think it's way more funny. It's like, Spanish is my first language, and so it's definitely my favorite movie of all times. I know almost all the quotes. What's my hobby? Well, weightlifting is one. Sometimes I don't really have much time. Lately, I discovered that I'm into cooking and baking shows, like competition shows, even though I don't really bake or cook that often. And why are you interested in psychology? I knew I wanted to be a counselor since I was an adolescent when I was in Mexico. I actually wanted to do psychoanalysis, but when I migrated to this country, I realized that it was going to be a hard journey. And then I started learning about, like other things and got steered away from that a bit. But I still got to learn a lot about Gestalt, and I do practice Gestalt a lot. And so then I wanted to supervise and teach counseling just because I realized that I really liked doing counseling. So it's kind of like a next level of like practicing what you love in like teaching and supervising like the new generations, and it's just kind of like one of those ways that you can contribute to the field, making sure that there's like quality services out there, that counselors have the support they need and things like that, especially those who are maybe minorities or, who are not necessarily exposed to a lot of different things. But yeah, that's it.
Now we are ready. Or are missing someone?
No, I think that's it.
Okay. I like to add like Dr. Jamie. I used to tell my patients, call me Oscar. I don't have any problem with the title. I like you, I prefer being called Oscar, and everyone call me Oscar too. It's fine for me. I don't know why, but it's something I talk with my supervisor too often, because he told me, but you're shooting yourself in the leg, but I don't like it. I like more being humble, and I believe in therapy that helps a lot, because people doesn't see me as a prepotent type of person. They see me like they're at their level or something. I don't know. I like it. And continuing, but what is a bipolar? Bipolar is a condition by extreme mood swings. So it's a I don't want to call it condition, but a disorder by the book. And is verdad, you're gonna have peaks of mania, and sometimes you're gonna have depression, but depression is not needed for the bipolar type 1. I don't know what is the level of the students. They are in the how far away from get the license they are.
They're currently in their practicum and internship experiences, so they're currently either just starting.
They are seeing patients already?
Yes.
Okay. Something I learned because when we get trained, sometimes we see patients and we start trying to guess what is the diagnosis, and we start trying to fill the criteria, but we forgot stuff when we do that. And we are detectives. We need to check it out. The things he's reporting, but we need to know what they are not reporting, because we cannot start with the premise that they know they have. Explain myself better. Sometimes they came to my therapy saying, I have nervous. And nervous can be something in my head. They have anxiety or something. But I need to ask them, what is nervous for you? And what is not nervous too? Because in this case, if you are seeing a patient came to your session with high levels of distrability, like a flight of ideas, verbal rate, talkative, and you forgot to ask about depression, maybe you're gonna miss the shot. This disorder, they are being related to abnormalities in the brain, in these neurotransmitters. I don't know if you get training on those aspects there, but how much you know in general about neurotransmitters?
I'd say they learn a little bit,
A little
maybe
bit?
yeah, a little bit in diagnosis. We talk about neurotransmitters, we talk about neurons. They get to see kind of like a brain cell and how, brain cells communicate with, chemical signals, electric signals. And then we talk a little bit about some of the neurotransmitters responsible for moods, and different regions of the brain that process them. But it's a lot of heavy reading in the class with other things, so it probably gets overlooked. So it would be good for them to have a review of it.
Yeah, because, for example, in bipolar disorder, you're gonna see high level of norepinephrine. That is some people call it adrenaline. Is the neurotransmitter that make you have more impulsiveness, and they call it catecholamine hypothesis. Is on balance of those neurotransmitters in your brain, and the medications, the thing that medications do is regulate that. But that is the thing I mentioned before. Not everybody in this planet have. I refuse to believe that. I refuse to believe everyone of bipolar they have problem with that. Maybe it's another thing. But that is something we need to continue searching, right? Or making research. Recently, they find out another, I believe it's monoamine, is a transporter for dopamine. It's not a dopamine, but makes the dopamine get to the place they need to go. And because he has deficiency of that monoamine, the dopamine cannot get to the place. And it's a new discovery that changed everything, because everybody thought was a dopamine problem. It wasn't. And affect the, it's a model called social interpersonal social reading therapy. y that takes the circadian reading as an issue to address, because during the day, your brain, so your system, your machine, use the chemicals, get depleted, or you don't have enough, and that change over the time, and you can have problem in the hormone secretion, and the appetite, and the temperature, stuff like that. And happen more acute with bipolar people. It's a theory. If we conceptualize the disorder about inheritance, Scott and McCartney in 93, they describe these three type of correlations. I clicked it. Correlation, that means when you inherit a trait, can be the three forms, can be passive, evocative, or active. When you were asking the question about why you choose the career, Miss Beth, excuse me, I use you as an example, but I remember you weren't choosing this career, right? You came to that career by not casualty, but the career if you gets you in, right? And that is a passive. You came to the career passively. And for example, other students said, no, I like to help. I like that thing. They choose the career because they want that. That is evocative, active. When you actively go to something and you have evocative is when you are having issues in your life and these issues make you being aware of that situation. And that is the major cliche in psychology, because most of the people in psychology career, they are not here by mistake. They are here because they want to fix something was broken before. And these three, if you took that theory in bipolar, but you can have the same thing in bipolars. People that inherit the thing by birth, people they get the thing while growing up, or they evoke to have the thing. It's something else called reaction range, can be related to the why kids doesn't show, or we cannot diagnose the disorder in kids. And reaction range is how your system or your body allows you to manifest the trait. And it's not the same for everyone. So some people are more easy. I don't know if you remember the theory about when the childs are easy to warm, easy, slow to warm, something like that. It's your body trying to limit the way you're gonna manifest the disorder. And that goes to the hand with the epigenetics that said we naturally have, we by nature, we have something that try to limit. It's called chemical cap. The DNA methylation is something, for example, I don't know if you hear about microchimerismo. Any of you are hearing about that? When the female is pregnant and she have a baby in the womb, it's a sharing of cells. In that sharing of cells, the mother pass something to the kid. Is the mother half bipolar and she's struggling with that thing, the mother makes some immunodeficiencies type of thing and prevent the kid to have it. But the kid have the traits in their genes. But the kid doesn't know. The kids, when the kids have kids, the trait came back. That's why we have concordance rates. The concordance rates from the father for the kid is lower than the father of the kid to the kid. You're gonna see that thing later, but it's very interesting how the trait jumps over generations. You're gonna see the trait very prominent in this generation and the Gen X, right? And the millennial not, and then came the nuevo, came back again the gene more prominent. This movie, Hillbilly Elegy, no sé how many of you saw it. I like a lot the movies. That's why I asked the movies in the first slide, because I use the movies with patients for let them know, understand the thing. In this movie, any of you saw the movie or not? No. In this movie, the grandmother, they are a very high expressive of bipolar disorder family, and the kids go away from the family because they don't want to be around them, and they try to change their life. And then I believe the old lady died and they need to come back and they need to face the roots of the problem. It's a good movie. And maybe helps you to understand the thing I was trying to tell about how the gene jumps the generations. And I believe most of you know what is the symptoms of mania. I don't know if any of you have any doubts of that. I used to do for remember me. I don't know if you know the mnemonic. Think fast. Any of you?
Can you repeat that again? The what?
The mnemonic. That mnemonic is the one I use to remember the symptoms of the manias. Because you know, mania and hypomania is the same symptoms. The only difference is the onset, 3 days or a week. But you have dig fast, distractibility, impulsivity, grandiosity, flight of idea, activity increase, sleep deficit, and talkativeness. It's very old mnemonic. And the other for depression is CG caps. And you need 3 symptoms of those. In the cluster, you're gonna have bipolar type 1, bipolar type 2, and cyclothymic. Any of you know what is the difference of those? Someone that want to share? for bipolar type 2, you can be able to have, let me see if I have the graphic here. You need to rule out the mania or hypomania. You already know the symptoms. You have a patient with the symptoms, you need to rule out if that is a mania or is hypomania. You're gonna rule out 3 days or a week. But the problem with that thing is the depression, because some patients came with depression too. But depression is not needed for the bipolar type 1. Once you have the bipolar type 1, you're not labeled as type 2. Approximately 60 or 70% of the people, they develop depression. But if you have bipolar type 1 and you have depressive symptoms, you cannot go back to bipolar type 2. You have both, or with depressive features. The symptom of depression, we need to be careful with that, because sometimes we have kids and elder people, and the criteria of, for depression, you need to have 5 symptoms. Let me see if I have the slide here. Okay, CG caps. That is the mnemonic, but you need 5. But one of them needs to be sadness or anhedonia. And anhedonia, I don't know if you know what is anhedonia. It's a word a lot of people don't use, but it's lack of pleasure. That's why I asked for the question about hobbies, because when you have a patient and you ask them, what is your hobby? I used to surf. But you don't surf anymore. Nah, I don't know. I don't want to surf anymore. That is anhedonia, or he doesn't feel pleasure anymore in the things he likes. And you need 5. One of them needs to be anhedonia, sadness, but with kids and elder people can be irritability. In the DSM, they level the kids, but the recent research, the elders, I believe 70 years or 60 years up, can be irritable. And you need to rule out depression. Before, we have several types of depression. We have now only mild depressive disorder and dysthymia, que is persistent. It's more easy for us because now before we have a lot of mild depressive, mild. We still have the severity, but we only have one mild depressive. We used to have depressive disorder. I don't remember the names, but was a couple ones. And you need to rule out if the person needs to have a week with the symptoms for depression, but for persistent needs to have the symptom for 2 years. If it's a kid or a child, it's 1 year. That is the graphic I want to share with you. In the yellow line, you're gonna see how the mania is expressed or by the patient. And you're gonna see here mixed features, and depression. When you are talking about bipolar type 1, you be able to notice depression doesn't get mixed. That is something important because for rule out bipolar type 1, type 2, is you have depression, but you need to know what you have. It's type 1 or it's type 2. And you're gonna notice depression is not in type 1. I put that image here, the movie Inside Out, to maybe help you to remember the scene when she told the sadness, be there, I have a word for you, be there, don't touch anything. It's the same thing. In this disorder, in the type 1, the depression doesn't touch. I don't know, it's helped me to understand the thing. So it doesn't get mixed. And here you have more in detail bipolar type 1. You need to have at least one episode of mania. Cannot be more explained by any other disorder from the schizophrenia spectrum. And for bipolar type 2, you're gonna have at least one hypomanic and never been manic, because if you get the manic episode, you are by type 1 already. And you can have, but it's not always happen, depression. And cyclothymic, you need to have a period of 2 years, but you cannot fill the criteria for either mania or hypomania or depression. It's like these 2 years, the patient have some symptoms, but doesn't get to a level to get the diagnosis. I don't know if you get that thing right. Is any question until now?
I have a not really a question, but I was reading over the bipolar type 2, and not like wanting to get the mania mixed up with, I guess, ADHD. So like the features of mania, which do they kind of correlate with symptoms of ADHD? And that could be something that we'd have to rule out before, like, we would have to rule it out before you even give them that diagnosis. But have you seen that it kind of mirrors a manic episode in your profession, like in your career?
Yeah, it's
Okay.
it's a lot of that. I have a slide with that information. Let me see.
No, we don't have. Okay, thank you.
No, but I have another one with the differential, because I saw recently in Facebook and Instagram, I don't know if you saw it, it's a promotion about hypersexuality, and they relate that thing to ADHD, and it's not true. The research said hypersexuality is more about bipolar. It's the manic episodes. ADHD have more risky behaviors relate to sex, but it's not hypersexuality. It's different because they lack of better judgment to make the right decisions, but that is not being hypersexual.
Yeah,
hypersexual is more bad to the manic type. And schizoaffective, you need to rule out that you need to learn how to rule out the thing. Depression, we already talked about. You need to fight the 5 symptoms for depression for 2 weeks, and one of them need to be sadness or anhedonia. You schizoaffective is a period of 2 years, and in these 2 years, you can schizoaffective is the schizophrenia cluster. That means you need to have the schizophrenia symptoms, but no more than 2 weeks with the symptoms of mood. If you have the mood, it's another thing. And the ADHD, you have a pattern of hyperactivity and impulsivity, and you're gonna have these symptoms ADHD and bipolar, they share some symptoms, but you need to rule out because, for example, in bipolar, the manic episode, they don't sleep, lack of sleep, and they don't get tired. But in the ADHD, they lost sleep and they get tired. And
Yeah, I was just interested in the differences of like what a manic.
that is a cute question when they came to therapy and you ask, okay, but how is your sleep patterns? And I don't sleep too much. But you feel tired? No? Yeah, okay. And we have a good metaphor. That is the specifiers of the, because I need to move the thing el tiempo. Anxious distress with fixed mixed features, rapid cycling, metabolic features is when they lost the pleasure in all the activities, atypical features. And I believe I never, it's very weird when I go to that thing. I believe the most important is to the diagnose by itself, because once you aim the diagnosis, the course of treatment goes to another way. And peripartum onset, that is more related sometimes to the microchimerismo I mentioned before, and I don't tell you, but microchimerismo is when the female is pregnant, they have the baby, the body you have a baby there, but the baby, when you gave birth, the baby is not there anymore, and you have an imbalance of hormones because your body is still trying to find the baby, and that's why we have the peripartum. Or seasonal pattern is the same thing about the regulation of neurotransmitters during the day or the seasons in this case. But it's something that I believe something to tune up the main disorder. I don't know if you get what I mean. When you finally, that person have a bipolar, what specifier has, and you're gonna go to the list and check it out, what is the specifier. And I don't know if you ever in the practice use the screeners for, I believe that for depression, everybody a lot of time use a PHQ-9, the GAT-7, all these ones, but not everyone saw for bipolar, for the mood. I use in therapy is very helpful when I refer patients. I used to, I cannot say that is something, a question. I believe Trevor made that question before about how approach the physician or the psychiatrist with the medications. I don't know what was him, was somebody in the chat, but for me work, when I see a patient and I notice he's bipolar or something, I make all the screeners and I put the screener in the file and I share the patient. So I make the referral with the screen side for not start doing back and forth with the specialist because they want evidence. And that is the bipolar spectrum diagnostic scale. We have that one. I use a lot the time this one, the Young Mania rating scale. That is the most famous, the people use that thing the most. It's very helpful. It helps you to maybe rule out the diagnosis very well. Este es the mania episodes. También that is very good too. I used to use that thing, but doesn't give me a lot of information. You mark there what the patients report, but in my experience doesn't help me more than the Young Mania and the energy schedule screener, because that goes more in detail. You will feel more energetic, active, and you're gonna notice when the people they have bipolar, they goes there. Yes, 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 yes. And you have all the the picture. That is the depression scales, the BDI-2. I don't use, I use, the most I use is BDI, the BDI-1 and the PHQ-9. That is for geriatric population because they don't used to report sadness, and that is useful tool for them. Happens to me one day because I have a patient and he seems depressed, but he doesn't have sadness, and that's what's struggling me. But how say the perfect picture of depression, but it's not sad. But I cannot give him the diagnosis. And then when I doing research, and but it's irritability, but that changed. In Puerto Rico, we used to say when you are assessing a patient or when you are seeing a patient, you need to learn how to make the questions. We have this metaphor about is have cat ears, whiskers, tail of a cat, and paws like a cat is a cat. But if he has a hypomania and has symptoms of depression and anhedonia, but that is not a cat. It's a cat with something more. I don't know. When I working with a patient, I have this cat in my head and helps me to make more questions because that is something we forgot. When we it's bipolar, pop up, and we stop. No, but continue, do more questions. Once in a week or 2 weeks, you feel the opposite. You feel when I ask them, you feel very high, very manic, or expansive. Oh yes, yes, yes. And what about the opposite? And that question is a game changing. That is the hypersexuality. And was a debate in media, but that's why I have the red thing, because I was asking some peers what they think about that, and they start doing hypotheses why people are using that thing as a merchandise. But the results study, they are not conclusive, but most of the studies said it's not hypersexuality, is not ADHD. It's involvement in risky sexual behaviors because the lack of making better judgments because the energy. Bipolar and ADHD share these symptoms: distractibility, irritability, accelerated speech, like a flight of ideas. And when it's mania in childs, you're gonna see that elation. Ay, le di otra vez. Elation is como en Puerto Rico we call it pavera. I don't know how you call it here, that, but it's super happiness. O sea, too much. Que tú dices, yeah, this kid is extremely happy. Grandiosity, flight of ideas, racing thoughts, decreased needs of sleep, but they gonna report. This one doesn't report fatigue. In bipolar, they feel super nice. And hypersexuality, that is the mania side. And other thing is a lot of bipolar patients, when they came to therapy, they don't want the medications because they feel very good. I hear that thing a lot. No, I don't want to get dope. Dope. I don't want medication. And I need to convince them to go at least get evaluated as a preventive measure after psychoeducating themselves, because I told them, until now you are fine, but what happens is that thing goes to a level that you cannot manage, and you finish in the hospital with a crisis or something like that. That is the adults, right? In adults. In ADHD, they're gonna report euphoric, elevated, or irritable mood, increased self-esteem or grandiosity, distrability due to the, but this distrability is to the thought acceleration and decreased needs of sleep. And ADHD in adults, they gonna feel labeled dysphoric. When adults became ADHD, they gonna, you don't need so many symptoms. They gonna, in some way, they mask the thing. They start having, instead of being deconcentrated, they start getting late to the appointments. They get forgetful. But you only need one symptom for the ADHD in adults. But these symptoms need to be when they were kids. So a lot of people now they said, no, I have ADHD, but never have symptoms when they were childs. That doesn't make sense. They want the prescription, most of them. But the truly ones, when you are an adult with ADHD, you're still having some symptoms. And part of the criteria is these symptoms need to be observed when you were a child before 12 years, I think. Before of age of 12, that the symptoms of ADHD needs to be there. And the sexual part, in bipolar, they're gonna have increased sexual activity, but in ADHD, they're gonna have a high rate of sexual disorders, greater involvement in risky sexual behaviors, and then the findings are inconsistent, but most of them point out that. So when they find the findings are not so significant, but we need to take in mind also the sample they took for measure. And again, it's important not confuse one thing with another. It's not a cat with elephant ears. It's a cat with cat ears. And I create some scenarios. I don't know. I like maybe go with each one with you, with the students, and discuss which one, maybe help them to find out the diagnosis, to see how accurate we're gonna find the symptoms. Who wants to read the first one?
I can read. It says, Emma, a 40-year-old teacher, presents to her primary care physician with a history of persistent sadness and loss of interest in activities she once enjoyed. Over the past 6 months, Emma reports feeling constantly fatigued, experiencing disrupted sleep patterns, and struggling to concentrate on her work. She describes a pervasive sense of hopelessness and worthlessness, accompanied by frequent thoughts of death and suicide. Emma's symptoms have had a significant impact on her daily functioning, leading to absenteeism from work, social withdrawal, and strained relationships with her family and friends. Despite attempts to cope with her symptoms through self-help strategies and social support, Emma feels overwhelmed and unable to find relief from her emotional pain. She acknowledges feeling guilty about being a burden to her loved ones and worries about the future.
In your clinical judgment, what disorder she has? She is 40 and she came with sadness. You have one of the criteria for depression, right? And loss of interest, you have the second one. You don't need it, but you have the other one. And fatigue, you have 2. Problem with sleep, problem to concentrate, and hopelessness and worthless. And frequently thought of death and suicide make the thing severe. Is depression, major depressive disorder. What gonna convert that thing in maybe in bipolar type 2? What we need for that?
Depression?
No, in this case, in this case, if we for make that case a bipolar type 2, what we need there in that case?
For bipolar type 2, I think you mentioned that we would have to have the depression and the mania together at the same time, because during bipolar 1, they will never be together. So if she's having depressive episodes, I would say, and I was trying to read if she was having
bipolar type 1 cannot be
2. No,
no,
it's 2.
no. I mean for bipolar type 2, what will we need for make that thing that
she would have to have mania symptoms. And right now I was
how
reading
long?
For just with, I think it's just with the couple of days, right? Well, at least one, yeah. Because then for the bipolar, wasn't it a whole week? One.
Bipolar, the whole week?
Yeah. So I would say bipolar 2, but I was trying to read it.
No. Because you need a week or 4 days. You need to rule out the mania. The only thing you need in this case for making a bipolar type 2, you need the hypomania. But it's not a bipolar 2. It's
just depression.
In this case, that is a good case to tell the patient, oye, Emma, any time in your life before that you feel the opposite, because sometimes she was feeling the opposite, but you don't ask. And this patient easily can go to depression route, and anybody know was bipolar. Because that is a patient came to your clinic, and the patient tell you, no, I feel like that, I feel like that, I feel like that, I feel like that. But if you don't ask, what else? Okay, you need to, how do you call it? Escudriñar?
And you investigate.
Investigate, like, let me see. And that is something we used to forget sometimes. That is Sarah. Who wants to read Sarah?
I'll read.
Sarah, oh, do you want rock, paper, scissors for it? Or, I mean, I can take it. It's all good. All right. Sarah, a 34-year-old graphic designer, presents to Dr. C's office with a history of recurrent mood swings. Over the past year, she's experienced periods of elevated mood, characterized by increased energy, racing thoughts, and impulsivity. During these episodes, Sarah engages in excessive spending sprees and takes on multiple ambitious projects simultaneously, often to the detriment of her sleep and personal relationships. Between these episodes, Sarah struggles with profound depressive symptoms, including persistent feelings of sadness, hopelessness, and worthlessness. She reports significant fatigue, trouble concentrating, and a loss of interest in activities she once enjoyed. Sarah's episodes typically last for several weeks, during which she experiences suicidal ideation and struggles to fulfill her work and social obligations. Despite recognizing the negative impact of her mood fluctuations on her life, Sarah finds it challenging to maintain consistent treatment adherence. She has a family history of mood disorders, with her mother diagnosed with bipolar disorder type 1, and feels ashamed of her own mental health struggles.
What do you think?
from my understanding of the information given here, and also with knowing a bit of her family history with mental illness, I'm thinking bipolar 2 disorder, because it doesn't seem as if there's like full-blown mania occurring to categorize as bipolar type 1, but there's also the inclusion of like depressive symptoms where she feels really low, and the times in which she has elevated mood aren't for, well, we don't have a lot of like information on time, but it doesn't seem like it's just hypomania or mania that's mainly present. So I'm thinking bipolar 2.
And because you need for the hypomania, what do you need for the hypomania in bipolar type 2? You remember? For both, you need 3 symptoms. You only need 3 symptoms, but for hypomania, you only need 4 days. It's a lot of people think if you have the 3 symptoms for a week, so it's like a waiting stage, but it's not waiting stage. The ones that have bipolar 2 is type bipolar 2. That doesn't change to bipolar 1. They are different things. If you have a week with the symptoms, it's bipolar type 1, but it's not that thing gonna become that. I don't know how to explain that thing very clear, but in the practice, when somebody have bipolar type 2, it's bipolar type 2. It's not something gonna change to bipolar type 1. And people think that thing and automatically, 4 days, and we need to wait a week to make it. No, it became bipolar type 1. That's why you don't return to the other diagnosis.
Yeah, but is it correct that like if there's a less severe form of mania, it would be classified as bipolar type 2?
You're gonna see that thing over the lifespan, the same pattern. But once change for bipolar type 1, that is the pattern. It's different. So the thing is stable. Think about it. The person have that thing for his life. In some way, gonna be stable in his life, the same pattern. The problem here is you to find what is his pattern. Because sometimes we miss the shot and we confuse one thing with another one. I like to not so focus so much in the diagnosis and meet the person, and you're gonna realize. And I am very humble with my patients. I told them like the things are. And when I make a mistake, I tell them, oh yeah, I made a mistake, my fault. So and they like that thing because they see you as a human that makes mistakes. And I remember one day I have a patient, the patient with the knife, the guy with the knife, and I know he wouldn't like it to go to the psychiatrist. And I mentioned the psychiatrist. No, I don't know what psychiatrist. Okay. But I already know he's bipolar. But I don't want to tell him the thing because I don't want him hating me for that. And I tell him, I think you may have that, but I like to confirm that thing. And the person that can confirm that thing is the psychiatrist. And he went and he came back with the diagnosis. And it was my fault. He told me I am bipolar. Thank you. You already told me, but I don't want to believe you. And he took his shirt off and he had a lot of tattoos. And he told me a story about the tattoos. And he told me that thanks to me, he knows he's not the tattoos. He's bipolar. So he even get a label in his skin. And that is another thing that you're gonna see in bipolar patients, that things goes in different things. The way he drives the car, the way they speak, the way they paint, the way they organize, the way they write in Facebook post. I am not diagnosing people, but you can see the traits. And people became very verborrheic. We call it verborrheic, but it's talkative. When they write paragraphs without smiling in the middle of the thing, and you can see the ideas jumping in the same script. So it's very interesting. It's called graphorrhea. Let me see what is. Who wants to read John?
John, a 28-year-old accountant, is brought into the emergency room by his family after exhibiting erratic behavior over the past week. He presents with grandiose delusions, believing he is a famous inventor destined to change the world, and displays rapid speech and flight of ideas. John reports sleeping only a few hours each night, yet feels energized and unstoppable, engaging in impulsive and risky behaviors such as reckless driving and spending sprees. Upon further inquiry, John's family reveals that he has a history of similar episodes in the past, characterized by extreme highs followed by periods of severe depression. During depressive episodes, John experiences overwhelming sadness, profound feelings of guilt, and suicidal thoughts. These episodes typically last for several weeks, during which he struggles to maintain his job and relationships.
Okay. What is your thoughts? I was playing here. I don't know why I can do that. Now I can right there.
I think it's bipolar 1 because of the grandiose delusions.
What else?
It says the past
How
week.
many you want? How many criteria? How many traits or? Three. And you remember the mnemonic, right? Big, fast, distractibility, and play of ideas, grandiosity. Aquí está, rapid speech, flight of ideas. You already have the three. And you have a week. And you have more. So okay. That is something you're gonna see with the bipolar type 1. So when you are working with type 2 bipolars, you're gonna have the symptoms less severe. But bipolar type 1, you're gonna see the thing very marked. Few
The
hours.
levels too, right? Like it has the sleep and then the energized and unstoppable.
Engaging impulsive and risky behaviors. Reckless driving. That is the thing when you see the mania patients, the way they drive the car, we automatically think about reckless driving. But for example, let me see how I said that because I don't want to self-disclose much, but I have a friend and she's bipolar. But she told me one day something about, I don't remember because her father was having a disorder. She told me something, but when she came to my home, her car smelled like brake pads, the brake pads of the brakes burning. And I noticed in that moment, she drive like crazy, and she hit the brake very, very hard. That is the way she drives always. And the car always smelly like a burn. And that is a thing coming from her traits. spending sprees. You already have the criteria for the type 1. What else they are giving you there? And now, what diagnosis we have there? What's your thoughts? What diagnosis you gonna give John in this case? Because you have both, but you have the type 1. What gonna make that thing a cyclothymic? What you gonna change here to make that disorder a cyclothymic? Because I can be able to change here periods of severe depression.
The intensity, it would be more like moderate depression.
Like you need for making that thing cyclothymic, he cannot achieve the criteria for depression or hypomania, mania. That means this past week must be maybe less severe, maybe 3 days, no more than 3 days of manic hypomanic episodes, and the depression cannot be more than 2 weeks, for a period of 2 years, because it already told you here, right? No. Yeah, but in 2 years. Si yo muevo esto aquí, se queda marcado. Ah, eso sí que no me gusta. Who want to read that?
I can read. Mark, a 26-year-old graphic designer, presents to his therapist with a history of mood fluctuations that have persisted for several years. Mark describes experiencing periods of elevated mood characterized by increased energy, creativity, and productivity. During these hypomanic phases, which last for several days to weeks, Mark feels euphoric, engages in impulsive spending, and takes on ambitious projects. However, Mark's mood also fluctuates into periods of mild depression, during which he experiences feelings of sadness, irritability, and low self-esteem. These depressive episodes are less severe than those seen in major depressive disorder, but persist for longer durations, ranging from several days to a few weeks. Mark finds it difficult to maintain consistent emotional stability and often struggles to regulate his mood effectively.
What is your thoughts? Yo creo que la dañé con la primera. Dejé de oír. No. Tienes several years, the change of mood, right? And you have high energy and productivity. That is something you're gonna see in the I don't want to say cyclothymic yet, but cyclothymic patients, they're gonna like some way of function better. It makes sense because they don't get all the criteria for hypomania or mania or depression. They are like almost there in both things.
And it is also because of the time.
Several years. You need only 2.
Yes. Okay.
You need it's a long period of time. When this time they have fluctuation in mood, depressive or manic or hypomanic or the manias. Bueno, maybe it's hypomania because doesn't get to the hypomania either. Some and they gonna tell you that they work fine. So it makes sense because imagine they when they came to you, they were being a long time with the thing. That tells you in some way they can be able to cope with the situation. It's not so severe.
Okay.
You get what I mean? So
Yes.
you have a patient, I have that thing for 3 years. And 3 years, he never came to therapy to fix nothing. That means that he was coping in some way. And if he was coping, it's because it wasn't so high to the level to need help. But the cue with the cyclothymic is when they talk about productivity and so they can be able to function in some way.
Okay. But in that case, okay, well, reading the DSM to follow the explanation, and it says criteria for major depressive, manic, or hypomanic episodes have never been met. So even when I'm seeing like some signs of characteristic of both of them, like manic or depressive symptoms, they can cope with them. It's not that intense. Okay.
Mira, te dice, these depressive episodes are less severe than those seen in major depressive disorder, but persist longer durations. Several days to a few weeks. Mark finds it difficult to maintain consistent emotional stability and often struggle to regulate his mood or affectability. When I read that thing, makes me think he doesn't achieve for depressive, but I click in the thing. But in your judgment, he has the depression or not?
Well, it says feelings of sadness, irritability, and low self-esteem. Depressive episodes are less severe than those seen in major depressive disorder, but persist for longer durations. Okay.
In the way I read it, he doesn't have it.
Okay.
But all depends. Because if have depression, entonces we can be able to be talking about type 2 bipolar. Or maybe we need to wait what happened. But that is the thing confusing with the thing because you can get confused here. I don't know if you get what I mean, but if you have depression, that can be bipolar type 2, and you are seeing a depressive episode now. But in the way I read it, I don't have the depression there. Mention periods of time of mild depression, but that mild depression is not diagnosis anymore. It's major depressive disorder, not mild depression. Feeling of sadness, irritability is not one of the criteria, and low self-esteem. You only have two.
Okay, I
You
see.
need 5 for depression, but doesn't have depression.
Would it be considered like a mixed episode then, since there's manic symptoms, but also like depressive symptoms?
But it's because he never filled the criteria for the manic. That is the thing. Doesn't get enough strength to get hypomanic and enough strength to be depressive. That is something you're gonna see in cyclothymic. Cyclothymic, they don't meet full criteria for any of those. But we need to be careful because, for example, if the patient came to you telling you, I feel sadness, irritability, and you take irritability as a trait, as one of the criteria, because if you have irritability, now you need 6, not 5. Right? Because irritability doesn't count. But if he was 66 years or a child, maybe we can take irritability like one of the traits. But even that, you have 3. It's difficult, right? But the most important thing is in cyclothymic, you cannot see the full criteria for anything. They're gonna have traits for that and traits for that, but doesn't feel completely for those and for more than 2 years. I see you confused, Dinah.
It's more clear. No, I'm reading. I can see the point. It's more clear for me.
Yeah.
Yes.
You're gonna have 2 years, and for example, what we need to convert that thing to a hypomanic. Several years, the present period of elevated mood characterized by increased energy and creativity and productivity. ¿Ves? Have increased energy y elevated mood. Only 2. Productivity can be goal-oriented, but I don't think productivity is too general. It's not goal-oriented. But if you put me there and hypersexuality, I have 3, yeah.
Okay.
And now we were talking about bipolar type 2.
Okay, I see.
Y si me pone, how long is the period? Several years, the expressive periods of elevated mood, several days to weeks. Okay, several weeks to bipolar type 1. But it's for 3 days. 3 days is hypomania, or 4 days. But a week, we're talking about bipolar type 1. And they can have depression in some moments.
Okay.
But it's not a part of the criteria. You get that part, right? For bipolar
Yes.
type 1, you can have depression, but it's not part of the requirements. You don't need it because that is even worse than that in the way I see it. Who wants to read Alexandra?
I can read. Alexandra, a 30-year-old marketing executive, seeks therapy following a series of tumultuous relationships and emotional crises. Alexandra describes intense and unstable interpersonal relationships characterized by idealization and devaluation of others. She struggles with a pervasive fear of abandonment, often resorting to desperate measures to avoid being left alone. Alexandra's emotional experiences are marked by rapid shifts from euphoria to despair, with intense mood swings occurring within short time frames. She frequently engages in impulsive behaviors such as reckless spending, substance abuse, and self-harming actions in response to her overwhelming emotions. Despite her desire for close connections, Alexandra's fear of rejection and perceived inadequacy often leads to conflict and chaos in her relationships. During therapy, Alexandra reveals a history of childhood trauma, including neglect and emotional abuse, which she believes has contributed to her difficulties regulating emotions and maintaining stable relationships. From what I read, I would give a differential diagnosis of bipolar 1, but from what I'm seeing, it's borderline personality disorder. There might be a comorbidity of bipolar type 1, but it seems like the main diagnosis here is.
I share with Bethany, I think, a case from a book, because by borderline and bipolar, they have some similarities. I don't mention in the PowerPoint, and I put that case precisely because some bipolar patients can be organic, is something in the brain doesn't working good, but I believe most of them is something social happening, and make them with poor skills to cope with the situation. And we are seeing a bipolar person, and it's not a bipolar person, it's a person with a lot of problems. And that is a case like that. And a person with a lot of problems can be a borderline patient. I don't know if you get what I mean.
Yeah, it makes sense. I think what I'm understanding is you're saying that there are various factors that cause what a client could be experiencing, and it's not always just one answer or one diagnosis. Sometimes
and that is the moment that when you work, get the value that the value deserve, because you are the one that can be able to identify that, because the psychiatric cannot see that, because they see the patient for 15 minutes and they very weird or rarely they're gonna see all this information. So they say, okay, vete, go away, take your prescription and go away, take the prescription and go away, and they don't have the chance to speak about the problems.
So I have a question. I know that the main focus of this training is bipolar disorder, but in this specific case, would you give a dual diagnosis of borderline personality disorder and bipolar type 1?
You can have both.
Okay.
And I have a, let me see if I find it, because I have a chart sent by APA with the similarities and the comorbidities between these two diagnoses. But one of the cues is the abandonment.
Yeah.
That part. Fear about abandonment is something that you cannot see in the bipolar. They don't care. They gonna lash out or whatever they have. Doesn't matter with who. But the borderlines is about somebody.
Yeah, and also I think taking into account that there's a history of childhood trauma and neglect and emotional abuse, gives another cue towards borderline personality disorder.
Yeah. In my opinion, borderline is something like a learned in, sabe, como que it's experiences you have in your life and shape the way you cope with the situations. I don't see that thing as a disorder too. This, if you think about it, makes sense. If you grow up in these circumstances, it's very understandable that you finish doing borderline stuff. And that's why we have you to let them know, to learn coping skills and stuff like that. And I don't know how many more I have. I don't put so much. I hope at least are being 14. Who gonna take Jacob?
Jacob, a 10-year-old boy, is brought to his pediatrician by his parents due to concerns about his behavior at school and home. Jacob's parents report that he has difficulty paying attention in class, often appearing easily distracted and frequently forgetting to turn in homework assignments. Jacob also struggles with impulsivity, frequently blurting out answers without waiting his turn and interrupting conversations. At home, Jacob's parents describe him as constantly on the go, unable to sit still for extended periods, frequently engaging in rough play or running around the house, and having difficulty winding down at bedtime. Despite spending a significant amount of time in bed, Jacob often struggles to fall asleep and wakes up frequently throughout the night, leaving him feeling tired and irritable during the day. In addition to his attention and hyperactivity difficulties, Jacob's parents also expressed concerns about his emerging sexual curiosity, noting his increased interest in sexual topics and body parts. However, they emphasize that Jacob's curiosity appears developmentally appropriate and does not manifest as hypersexuality or inappropriate behavior.
There is another case, I believe, go away from the cluster we were studying, but I put it on purpose to see a case that when we gonna see the thing, right? What is your opinion?
ADHD.
Mm-hmm. And it's that is something you're gonna see, and people confused with the it's a kid, but it's the sexual curiosity. That is the thing. It's not activity. And in this age, I believe most of the people have curiosity, start having this curiosity in sexual things, right? But gonna be a little bit increased with ADHD. But it's not telling you risky hypersexual behaviors. I put that thing there. I don't know. Bethany is here.
Yes, please.
Yes.
We gonna take a break or not?
We can take a break, whatever you
No,
prefer.
I fine. I can continue, but I don't know if somebody want to take a break.
Yeah, they're allowed if they need to like step out for like 5 minutes, like that's totally okay. But yeah, you have until like 1:15, so it's up to you if you'd like to take a break. If not, then we'll just continue.
Okay, and no, I left to you to decide.
Okay, well, we'll
because
continue.
it's tough. It's a lot of information. I have another
Yes.
aspects to discuss. But
They'll get a break after you're done presenting because we have an activity for them, so they'll get a break. And also I did send out the case study and the extra materials that you sent to me. So they were sent out everything this morning and they'll have access to those resources that you sent.
No, but I was thinking another thing I have. I don't sure if I have it. I still have it because it's old, but I can't find the new one. But I sent to the students like I don't know if counselors do that. I don't think, but you don't do plant treatments, right? You don't need to do that.
Like treatment plans? Yes,
Treatment
we
plans,
do.
but by no, I know you can do it, but
Yeah.
I believe the board doesn't require that thing. It's like but even that it's not important. I send a treatment plan in the interpersonal social reading therapy. I gonna talk about that thing later. But you want me to continue?
Yes.
Now? Okay.
Yes.
Mira, and other aspect to take in mind, right? We can have a. I already say that thing because when you have this energy in your body, in your system, that's gonna affect the way you behave, the way you drive, the way you work. So the guy I told you earlier that came here crying because he feel crazy, he was telling me, "Hey Oscar, my peers at my work hate me because I work too fast and they want to work slow to not work so hard, and I'm making them work harder because that energy." And he started dysfunctioning, and that is a good example how the bipolar thing is make his life even worse. And earlier I was talking about the concordance rates, and you're gonna see when you have a second degree relative, grandparent, uncle, you have a 5 to 10%. And when you have them in the same blood, in the same line, you have the 10 to 15. Why? Because you are most exposed to the thing. And the thing continue going. It's a theory called, I don't know if you study Powenian family therapy. Is something you study there?
Yes.
And you know what is the main thing about Bowenian therapy?
Yeah, like genograms and family mapping.
Y él do that thing because when you do the genogram, he said you can see the disorder in the levels. And they call it they use that thing to explain the schizophrenia, and they call it multigenerational model. So you do the genogram and you make the patient to understand from where the disorder came and how the disorder are being expressed in the family. And that's why you can see in that way you can see the concordance there. And when I was working with the guy, I was asking him in his family, and he can be able to target in his family all the people with the disorder. Was good because was less blame on me. And cultural prevalence of bipolar, I believe we are not the most ones, but it's more prominent in white people, followed by black, by Hispanics, and then black. I don't have the ones in order. And Native American is the highest. I don't know why. Maybe it's because they are more eccentricity population. That is something that I told when we start. Maybe they see their behaviors at bipolar, and it's not bipolar, it's the way they are.
Like because of the culture, like
by the culture.
Okay.
And it's the same thing with Hispanic and Latino.
Mm-hmm.
But I don't know why. Bueno, sometimes this concordance came from studies made in some populations. That is the thing I mentioned before, the wear samples. I don't know if you know what is that, but the wear samples is in psychology, most of the tests are being made with white people from Minnesota, most of them. And the wear sample, se llaman weird, is Western industrialized, educated, rich democratic people. Weird, it's an acronym, but these people is the sample for the test. And that makes sense when they, maybe if you think about white people, maybe they behave more expansive. That is risk factors. And if I remember good, the statistics for suicide is 30% for bipolar, but having a previous attempt increase the risk. Family history of suicide increase. Substance abuse, Trevor said right before, was talking about the substance abuse is something we need to address. Severe depression, mixed affective states, psychotic symptoms, and lack of social support. I believe that is for all the disorders, chronic medical conditions, and recent loss and not adherence to treatment. That's why rapport is so important, because in my opinion, that is the best thing. I believe with my patients, the patients that I see more better outcomes is the ones that I feel I did less. I feel that because I don't feel I provide a lot of psychoeducation or techniques or something. I believe and it's something a lot of psychologists hate that thing. I don't know if you hear about Heinzek. Heinzek in the 1950s, he made a research and he find out therapy doesn't work. The people, they cure by themselves. And a lot of psychologists hate him because that. People after him came and they tried to fix the thing. This guy doesn't measure the thing so well. And they find out another numbers. And they said people from therapy, they get good outcomes, and they came with statistics of 80% of people in therapy get better outcomes than non-people in therapy. But they said the Heinzek doesn't make a fair study, and is something that in psychology a lot of people hate him. He was very important figure in psychology, but a lot of people hate him because of that. And when I told you about the high expressive language, that is something you can see in bipolar patients. They have this energy, and that energy gonna get out from all places. It's like in psychoanalysis, we use the metaphor about it's like when you see a high tension electricity cable, this high voltage cables, like sparking energy. But they use that metaphor to explain how a bipolar person function. And that is from Puerto Rico. She's a influencer / I don't know, popular girl. And I bring that video. I don't say she is bipolar, but she is using high expressive language. That is something you can see in bipolar patients.
Te voy a decir una cosa. Con la nena no. Me deja la nena quieta. Yo es que decía, ese programa es una porquería. Yo no voy a gastar mi tiempo viendo esto. De que Maripili lo está poniendo todo, mira, en su sitio. Low key, esta soy yo ahora. Ajá. Dilema. Sí, a mí me sacó.
Entonces, there you can see a little bit how the high expressive language came from the bipolar, but I cannot say she's bipolar. But the high expressive language have it, and can be something cultural, because I came from Puerto Rico, and a lot of people do. It's like that in Puerto Rico. It's not need to be bipolar. And treatment options, we already talked about the thing, medication, psychotherapy, or lifestyle adjustments. I believe that when I mentioned the patients, I see better outcomes. I believe when they do lifestyle adjustments, I see the outcomes when they change their lifestyle adjustments, and not so much with psychotherapy, in my opinion. But of course, I do in psychotherapy, but that is the way I feel. And mood stabilizer, antipsychotic, antidepressants, or a lot of people, it's another joke because the SSRIs are getting very famous. And they said they are good even for everything. And the catecholamina hypothesis talks about how in the brain high level of dopamine and norepinephrine is related to mania, and low levels to depression. And serotonin levels is another theory called permissive hypothesis. Let me see if I have that hypothesis here. No, I don't have it. But Jimmy told me that you already know about the transmission in the neurons, right? How that thing works. But when you have low levels of dopamine in the cortex, you're gonna have a low. Let me see if I have the picture, because the ventromedial, this area here in the brain, take control over this part, and this part is the dorsolateral area. When the person has depression, you cannot see activity in that part. That is something we address with the TMS. When people came to the treatment with TMS, we put it's an electromagnetic device in the head, and it stimulates that part of the brain and make that part to start working. That part works with the planification, and it's movement, but it's activity. That's why depressed people, they don't do nothing. They don't want to do activities, and they stay at bed in the home. When they activate that part, they start doing stuff. And we hear here like a statement, people became more like one day we have a patient, and she also said after the treatment she started having sexual desires again. So the thing, and because I am very skeptical sometimes, and I put myself in doubt, and I go to the research to see, and I said, no, that thing is being paid by insurance policies, is because work. And then the patient came telling that thing, and to validate the thoughts I have in that moment, but I don't tell her that thing. But so I was doubting, that thing work or not work? And she came, no, you know what? I start feeling like something spark again. And that is the concordance race I want to show you about. That is the mood stabilizers. It's something I found another research that said that some people with depression, they get better outcomes with placebo pills instead of SSRIs. And for me, that doesn't make any sense. And when I was talking with my wife, she told me, no, the problem is the medications doesn't have a very big percent of effectiveness. Mood stabilizer, the 50 at 70%. Anticonvulsant, 40 at 60. Atypical antipsychotic, 40 and 60. Antidepressants, therapy, 30 and 50. So therapy is not so much. The best treatment for depression is ECT, but it's very dangerous, or how do you call it? So people lose memory. So it's harmful, but work. And lifestyle and psychoeducation is casi almost like therapy. In this way, maybe you said, but we don't do a lot, right? But we do. I believe, because not all the people are on those medications. And I believe most of the people are in this antidepressant with mood stabilizers, 30 and 50, and it's comparable with therapy. Okay. Aunque los even when the psychiatrist didn't like it, our work is comparable with their work. I believe in my experience, I believe we do more because we are an hour with the patient. And they don't used to be an hour. They see the patients very quickly. And that hour make a difference. And it's something we do here. I want to share with you because it's something not a lot of people knows. And I believe that is you can get access for that when you were practicing, but it's genetic test to see what medications work with you. And you fill a form online, they send you the package, and they make a test on your system. It's a genetic test, and they can tell you which medications are more works better with you. But here, that is something we do because we used to do in Puerto Rico. But when we came here, we noticed anybody is doing that. They are not doing that, and it's very good. I have patients that with the gen site, and they came with result that they cannot use that medication or the other medication, and change the game. And it's important you to remember the guideline for bipolar is interactional social reading therapy. That is the guideline. And the other thing is CBT. A lot of people use CBT because CBT have the psychoeducation part. But it's the psychoeducation the biggest, the strongest tool for them. And the interpersonal social reading, but they help two individuals, ¿verdad? with this condition to stabilize their routines and improvement. That is like the patient I told before that I was trying to educate her in this model, and when I mentioned her about the time frame, she opened the eyes very big and she told me, I did that. And I was asking her, but how? Me said, I noticed I was paying attention to my body and my situations, and I realized 3 p.m. every day, I feel very sensitive. And it's interesting because when I start seeing her, I was seeing her because she has problem with the husband. And through the therapy, I include the husband, and situations happen in therapy. Sometimes she gets mad at me and she dysregulates. I tell the husband genuinely, I tell him, you know, I was very lucky with your wife because she's still coming. Because one day she get mad at me, but I let her process the feeling. And then I send a message, oh yeah, that happened today, but you know, and I was sincere with her. And these interactions help them to copy in their relationship the same thing. And that is the thing that interpersonal model looks out to incorporate. How do you relate with your relatives in better way? And was very good because he started doing stuff like I did in therapy with her in the home. And she came to therapy reporting the thing. And she told me, no, you know what? He do that, and what's good because he allowed me to process my emotion, get regulated, and we don't fight. I have a book that is a treatment plan for interpersonal social reading. And in this model, you make the diagnosis. You need to get the blame. You put your name. I believe that they send that thing to you, to all the students. You can use it, and you're gonna stabilize the mood. You can do like a 1 session or 2 session in that part, and that is disclosed in session and interventions. But it's good because when I was a student, anybody give me something like that, and I need to learn by myself how to do the treatment plans. But there you have all the things you need to do with a bipolar patient in this model, and you have the reference from the book. And the increased understanding, that is psychoeducation, is from CBT. The psychoeducation aquí otra vez. Regular daily routines, that is the social reading therapy. Interpersonal therapy is the relationship, and social reading. I believe it's a very good model. Bueno, it's the guideline, must be good, and explains a lot. And if you notice, doesn't talk nothing, sabe, talk about the medication adherence, but it's the interpersonal situations, the problem. The people doesn't know how to handle the situations. That is the thing that my patient learned, how to handle the situations. And by increasing awareness of the implication, ¿verdad? You can foster empathy in the patients and to eliminate the stigma. I believe the stigma is the biggest thing in this disorder. People hear the word bipolar and they think that the worst, and it's not need to. And I was formed in Lacanian. I believe that is the thing that makes me get more successful with patients like her, because Lacan in the work, I don't know, it's something I like to share with you because it's something I used to do. He has some positions in therapy that you can go. For example, in this moment, I was telling you all about something, and I am in a position to speaker. But when you are with the patient, you cannot be in that place, because when you have a bipolar patient came to your session suffering, and you start telling them stuff, they cannot return. This psychologist, I cannot go there anymore. He doesn't even let me talk. Let them talk is more important than you talk to them. And that's why I bring that the Lacan thing. And I create a quiz. I don't know if you can see the quiz online. I put there the link. Or we can do as a group here. How do you prefer? Vamos a hacerlo aquí. I believe it's only 10 questions.
Can we do it as a group so that we can all learn together?
Bueno, you can copy that and save it and use it later, but we can do as a group here.
Yeah, let's go ahead and do it as a group if that's okay.
Okay. And you're still seeing the page, right? Okay, group.
It still says quiz. It might be your slide that's still showing us.
¿Cómo se dice? Share your screen. No me deja cambiar. Share this tab. Stop share. And share again. ¿Cuál será? Este que está aquí. Ahora sí. Entonces creo que lo puedo poner más grande aquí. No. Now you can see it, right? Well?
Yes.
Yes.
Okay. But who want to read?
I can read.
How many typos I made there? I do my verbal typos than writing typos.
That's okay. A 32-year-old man reports 1 week of feeling unusually irritable. During this time, he has increased energy and activity, sleeps less, and finds it difficult to sit still. He also is more talkative than usual and easily distractible, to the point of finding it difficult to complete his work assignments. A physical examination and laboratory workup are negative for any medical cause of his symptoms, and he takes no medications. What diagnosis best fits this clinical picture? I'm stuck between hypomanic episode and bipolar 1 disorder with mixed features. Anyone else have any
What
thoughts?
is your rationale? Mira. You have a weak, irritable, and he's at 32 years. During this time, he has increased energy and activity, sleep less, increase energy, activity, and activity, increase sleep less, and find difficult to sit still. Okay, you have the 3 symptoms. He also is more talkative than usual and easily distractible. You have 2 more. To the point of finding it difficult to complete his work assigned. It's difficult, he's not functioning. A physical examination and laboratory workup are negative and any medical cause of the symptoms, and he takes no medications. What is ruling out anything substance is something that he has. And what do you think?
I agree with Tosin with the bipolar 1 disorder with the mixed features.
With the mixed features. Because the irritability. We all agree?
Yes.
Yep.
Okay. Pero no nos va a dar la respuesta ahora. Nos los va a dar al final. Está bien. Pero yo las tengo acá.
I'll read this one too. A 42-year-old man reports 1 week of increased activity associated with an elevated mood, a decreased need for sleep, and inflated self-esteem. Although the man does not object to his current state, I'm getting a lot of work done. He is concerned because he recalls a similar episode 10 years ago during which he began to make imprudent business decisions. A physical examination, laboratory work are unrevealing of any medical cause of his symptoms. He had taken fluoxetine for a depressive episode, but self-discontinued it 3 months ago because he felt that his mood was stable.
When do you gonna take your licensing exam? Because you are doing an internship, right? Or you are?
We usually take it, there's an opportunity to take it towards graduation, and then there's also an opportunity after graduation.
Puerto Rico, why don't do that? I hear that thing from someone that you can do that thing before. But that is the type of question you're gonna get in the test. And what is the answer?
This one's kind of confusing because it kind of seems like a hypomanic episode. So I'm not sure.
Hypomanic, but you have a week.
Yeah, that's the difference. It's not days.
Yeah, but then there's no mention of impaired social or occupational functioning.
No, because you only need 3 symptoms for a week. And you have elevated mood, decreased needs for sleep, grandiosity, and I'm getting a lot of work done. Yeah, but he's working, but it's irrelevant. He's still having the problem, right? He's concerned because he records a similar episode. 10 years ago, he has a similar thing. And That is the case.
I'm seeing characteristics of manic episode, but it's not there. So
Mhm.
I could think in bipolar 1 disorder.
I agree. Would be great to see the answer, but I forgot to put it because I leave it hide it for all you. But by that we all agree bipolar 1. That is that I believe that question was one in one of the slides. But it's a I believe it's a difficult question, but I believe it's 10%. Let me see. Because we don't went I stopped, right? I moved something here. Mira, bipolar disorder is highly recurrent and more than 90% of the individuals who have single manic episodes, the 90% of the people, they have a manic episode, they're gonna have recurrent episodes. That's why when you have a patient like the previous explanation, when he said 10 years ago he has some similar episodes, it's 90% you're gonna have again the thing. That's why you have a patient today and the patient came with maybe he told you, I feel the grandiosity. He gave you only 2 symptoms for 4 days. And you ask him, oh, okay, but any time in your life you have the same thing? And he told you, yeah, the 2 years ago I was hospitalized because I was so manic. And you know, for sure he's because that's rates. The 90% of the people with that, they're gonna have it again. And you are seeing now the ¿cómo se dice? The first stage or something, ¿sabe? He's going there. Now, who gonna take that one?
I will. In which of the following ways do manic episodes differ from attention deficit hyperactivity disorder, ADHD? Manic episodes are more likely to involve excessive activity. Manic episodes have clearer symptomatic onsets and offsets. Manic episodes are strongly associated with poor judgment, or manic episodes are more likely to show a chronic course. Manic episodes first appear at an earlier age. Episodes differ. I'm going to say manic episodes are more strongly associated with poor judgment. I don't
know. Why?
Because I think you mentioned before about the differences, and I thought one of them was I'll try to see where I wrote it.
But we talk about the 90%.
Oh yeah.
I believe manic is more chronic thing. I believe it's something that when you get to your test, that type of answers is very like we call it in Puerto Rico coge bobos.
Okay.
Because they gave you sometimes they give you more than one possible right answer, and you need to choose the best one.
Okay.
The one you gave me is good, but the chronic is even best.
Okay.
And sometimes we need to make that thing, because ADHD patients, they have poor judgment too, and they have manic episodes have a clearer symptomatic onsets. They share some symptoms, and activity, both have the same thing, both have the same thing, but manic episodes are more chronic, in my opinion. But
Okay.
it can be wrong.
That's a tricky one.
That's why we call it coge bobos.
Thank you.
But nos cogió bobo a los dos. It's clear onsets. And the rationally said, ADHD and manic episodes are both characterized by poor judgment, excessive activity, impulsive behavior, and denial of problems. Patients with ADHD have an earlier onset of illness, and the age of 7, show a more chronic courses. Manic episodes are more episodic and lack of clear onsets and offsets of symptoms. In addition, ADHD patients tend to not have an unusually elevated mood. You know what? Vamos a hacerlos acá. No tenemos que hacerlos ahí. Los tengo acá en esta página. Aquí está la otra. Ay, no, ya la choteé. ¿La llegaron a ver? No. ¿Quién lee esa? Who gonna read that one?
A patient with a history of bipolar 1 disorder presents with a new onset manic episode and is successfully treated with medication adjustment. He notes chronic depressive symptoms that, on reflection, long preceded his manic episodes. He describes the symptoms as feeling down, having decreased energy, and more often than not having no motivations. He denies other depressive symptoms, but feels that these alone have been sufficient to negatively affect his marriage, which diagnosis best fits this presentation. Other specified bipolar and related disorder, bipolar 1 disorder, current or most recent episode depressed. I go with C, like cyclothymic disorder.
A new onset. He's presenting with a new onset of manic episode because he had another one before. And he's usually treated with the medication and adjustment. He notes chronic depressive symptoms that, on reflection. What is your answer?
Wouldn't it be B, because we already know that he's had bipolar 1? So it would just stay after that.
¿Cómo va a ser?
Okay.
Because the preparation, I don't finish to read. Where said there, because for dysthymia you need to have 2 years. He described the symptoms. I don't see the time frame. And that came from the book of the it's from the book.
It says on there that he notes chronic depressive symptoms that long preceded his manic episodes, but there is no like actual
Nighttime, but maybe it's I have a book of DSM of questions. And that is one of the questions from the book. So it's not a question made by me. But I don't know why they make that question without time and then say that it's persistent. Explanation. The patient presentation does not meet the full criteria for a major depressive episode and thus will not qualify for a diagnosis of bipolar 1. Current most recent episode depressed of the patient meets criteria for persistent depressive disorder and a bipolar 1 but should be diagnosed. The presence of manic episode makes a bipolar 2 disorder. Doesn't make any sense. But when we finish, I'm gonna go to the book and we're gonna check that answer because I don't like it. Mm. I like to do that thing because if that is the moment we have the doubt, it's the moment to correct the doubt. But maybe it's the version of the DSM. Bipolar disorders.
I wonder if dysthymia isn't the DSM.
It's persistent. No, dysthymia is not there anymore. It's called persistent depressive disorder.
Okay.
But let me share with you the page. Stop share. ¿Dónde está el book? Ese es el libro. That is the libro that I took the question. But I struggle to find the bipolar. It's here. But doesn't take me to the doesn't take me to the page and doesn't let me waste is the page. But chapter 3. Chapter 10. Okay. And the question was, anyone remember I believe it's that one. 42 years? No. Somebody remember how remember when we actually irritable during, it's not that one too. Okay. That is the one that Trevor read, right? The work tone. Ajá, 90%. Which of the following factors most predictive in community? No, esa ya no la puse.
It's
Ajá,
not that one.
ahí está, 97.
3.7.
37. And there is the explanation. It's the same thing. But doesn't make any sense because it's don't have a time frame. But maybe it's because the edition of the book, maybe we are thinking about the DSM-5-TR and they took out the dysthymia from the page, and that in those times they have another criteria. But because that is the test question from the Philip Martin Muslim. But maybe it's that. And maybe we are thinking like the new DSM and they are using the question in the old terms. And that's why it doesn't make any sense for us.
Can you put again the question just for a little bit?
Mhm.
Just to-
Because the only thing I don't like about the question is doesn't give us an onset.
New onset.
It's very vague. A chronic depressive symptoms, but doesn't, chronic can be less than a year, right? Or a year. But for dysthymia, I need 2 years, but doesn't say 2 years there in any place. But that is a case like, no, that must be the opposite. Because maybe he have a diagnosis of bipolar type 1. Incorrectly made. But I don't like the question.
So bipolar disorder can be a tricky one to diagnose. Yes.
It's tricky. De hecho, the patient I have, the one I share with you about with the husband, yes. This patient, I know she's bipolar, but I never tell her the diagnosis. I treat her as a human. I don't talk about diagnosis and anything or skills, stuff like that. And one day I tell her what diagnosis you have. And she doesn't, I don't know. Yo, okay. What diagnosis you gave me? Yo, I don't have you there in my papers with bipolar, but maybe you are. But I was being humble because I don't want her to start believing she has a bipolar. So like taking the stigma. That is something I don't like to do with her. And I asked the paper and she came with bipolar from the psychiatrist. But I was being humble with her. I don't want to make more stigma on her because I know how she felt. But this question, I don't like it. I forgot to see the year of the book, but then now we have an onset, a week of elevated expansive mood. Okay, you have a week of symptoms, but how do you gonna rule out is a manic or hypomanic? And I believe that is the thing that Trevor said before. Now, yes.
Yeah, so it'd be C.
The functioning. The functioning is look at that determines if the person have hypomanic or manic. I forgot one thing is but this is basic is if the patient has been hospitalized because the symptoms, but I don't like that too much because he can be hospitalized incorrectly, and I have a lot of those here. I have a lot of people that said, I was thinking about that, and people get stressed about that thing too often, but and it's a problem because people said that they get hospitalized, they get treated in the hospital because they have a thought about being dead, but I believe every person on this planet in a moment of desperation thought about that death, right? It's a normal thought. But trying to kill yourself is another thing, different. Thinking is another thing, is a thing, but the behavior is another thing. But you hospitalize a person because have a bad thoughts in your head, and then they came to therapy, they don't trust us anymore. They don't want to speak out, and then they start hiding information. And happen here. That is a tricky question too. Sometimes I tell students, because it happens to me sometimes, we assume we know the meaning of the words. It's a bias we have. Everyone has the thing. You assume you know the information, and then you realize you don't know. And for example, if I ask all you what means agora, what means that word? I didn't know the last week. It's super easy, but I know what is agoraphobia. Okay. But I was thinking, what means agora? Because I want to know why they put agoraphobia to that thing. And agora means place. But I never look out for the word. I was assuming. I buy it automatically. And I tell that thing now because I read something chronic. Chronic, I think, means a long period of time, but maybe have more implications that I don't know. It's because I never look for the definition. I don't know the thing. Happens, for example, in Puerto Rico, when you have a seizure, you can lose your consciousness. In Puerto Rico, consciousness and self-aware is the same thing. Here, not. And a lot of people when they answering the test, they answer the wrong question because they think it's the same thing. But here is different. Here is different things. Consciousness, you are dead in the floor and conscious. Loss of awareness, you get like a knocked out, but you're there, but you don't know. So you are like a impaired awareness. But in Spanish in Puerto Rico, both are the same. And I make the exercise. Let me check what means unconsciousness. And I realize the differences between the two statements. Sounds silly, but we are full of this silly stuff in their heads. Or for example, when a patient came here, and tell them, when we're talking about that thing in psychoeducation, I was trying to let them know more about that thing and tell them what for you is an antisocial. And a lot of people tell me, it's a person that doesn't like to go out, doesn't like to hang out with people, and stuff like that. And that is not an antisocial. An antisocial is a people that hates people and broke the law, steal, doesn't have remorse. The person you describe is asocial. It's different. And we are navigating the life with a lot of biases. And now I was about to look up what means chronic, because I think maybe that's why we answered the other question wrong.
So is this one D?
D? Involve shorter symptomatic episodes than course of bipolar type 1 disorder. The difference between the bipolar 2 and 1. That is the thing you think by logic. But I think bipolar 2 is more chronic, because the bipolar type 1 have shorter periods. You are not the whole year with the thing. But the bipolar 2 is more chronic. And that's why I was trying meaning. Ve, mira, maybe for you, maybe it sounds silly, but because my native language is Spanish and I'm translating, and in Spanish, we have the language Spanish is very dense, and English is more compact, and you have different words for stuff, and we try to put the words in Spanish, and we miss a lot of shots. For example, chronic means constantly recurring, persisting for a long time, difficult to eradicate. And you said D. I believe is the A, but I don't remember. But I believe the bipolar type 2 is more chronic. Right? Because it's more chronic because you have the whole year messed up. The bipolar type 2 have more the type 1 have more the onset acute onset. You get hospitalized and you get out and fixed for a couple of months. You
like fluctuations. I'm sorry.
The fluctuations, yeah.
Okay, I guess I was confused because in the presentation, the thing about bipolar 1 being like a week and then bipolar 2 being like 4 days.
No, that is the onset for the manic episodes.
Okay.
And that is the criteria.
Okay.
But that time frame is the criteria. You need 10 days for that. And it makes sense. Your logic makes a lot of sense. But the course of the disease or the disorder in the big spectrum is more chronic, the type 2, because you're going to have the patient in your clinic more time messed up. The bipolar 1 going to have shorter periods of onsets. It's different than the criteria. When I another way to picture a manic patient, like you see the girl I put in the video, but I don't know if you see the movie Mask.
Mm-hmm.
When he put the mask, he's manic, but he's not manic all the time. It's time he put the mask. But the bipolar type 2 hypomanic is always hyper. That makes the thing more chronic. I don't know if it's a good example, but for sure you're gonna have friends like that, because I have a couple of friends like that. And it's difficult because they make you feel tired. You cannot, it's gossips. It's not confirmation about that thing. But Michael Jordan, a lot of people said he mostly be a hypomanic person, because the thing he do, the other players said, I don't know how we can do that stuff. He was practicing, he went out, we hung out, then he played golf, and he always was doing stuff, and he never gets tired. And playing to that level and never gets tired is not human. So it sounds stupid coming in this way, but if you think about it, how come somebody can do all this stuff? And maybe he's type 2, bipolar type 2, but he never get depression because he's happy. The things goes fine for him. So okay, una combinación is maybe in his life he never have the chance to get the depression so big. I think, no sé. Everything can happen. But the thing is, now you know that type 2 is more chronic than the type 1. And when you have a client with type 1, you expect the client to came, sometimes. For example, I have a friend in Puerto Rico, and she's another friend, and she never disclosed to me she's bipolar, but I believe she's bipolar because I noticed when she disappeared from Facebook. And I know her, she's very high, so she's very a level that even her sons doesn't tolerate her. But she knows she's not always like that. She has periods of times. But some people, they are all the times hypomanic. Hypomanic means a little bit less. And manic is like a mask. And she's like mask, but not todo el tiempo, sometimes. The worst prognosis. Married. It's a joke. I don't know. But think about it, for schizophrenia, having family with high level of, ¿cómo se dice? Emotional, high expressive emotional pattern, like the girl in the video, for a schizophrenia is a bad prognosis. It's a high risk for relapse. But worse prognosis for bipolar 2. What do you think? We gonna guess here, because the question, the answers are, in this case, anyone seems to apply, but I think I know what is.
Is it C?
I think it's C. Because marital status doesn't make sense. That at the opposite. Being married have better outcomes for a lot of diseases or disorders. Less severe depressed episodes, you need to have a depressed episode anyways for bipolar 2. Younger age is, I don't see that thing in any place. I believe it's the C. You're right. You want to read the thing or no?
Sure. Yeah, so a rapid cycling pattern is associated with a poor prognosis, return to previous level of social function for individuals with bipolar 2 disorder is more likely for individuals of younger age and with less severe depression, suggesting adverse effects of prolonged illness on recovery. More education, fewer years of illness, and being married are independently associated with functional recovery in individuals with bipolar disorder, even after diagnostic type 1 versus 2. Current depressive symptoms and presence of psychiatric comorbidity are taken into account.
Bien larga. Todavía Aren is here. Y que no te he oído hablar. I hope that we still having one for Angie, one for Price, one for AB.
You want me to read it?
I don't know. I mentioned names.
A 25-year-old graduate student presents to a psychiatrist complaining of feeling down and not enjoying anything. Her symptoms began about a month ago, along with insomnia and poor appetite. She has little interest in activities and is having difficulty attending to her schoolwork. She recalls a similar episode 1 year ago that lasted about 2 months before improving without treatment. She also reports several episodes of increased energy in the past 2 years. These episodes usually last 1 to 2 weeks, during which time she is very productive, feels more social and outgoing, and tends to sleep less, although she feels energetic during the day. Friends tell her that she speaks more rapidly during these episodes, but that they do not see it as off-putting, and in fact that think she seems more outgoing and clever. She has no medical problems and does not take any medications or abuse drugs or alcohol. What is the most likely diagnosis?
What do you think?
I couldn't think while I was reading out loud, so I have to reread it.
But you have anhedonia, right?
I didn't see any. Oh yeah, a
No
little.
enjoying, enjoying nothing.
Yeah.
Your symptoms began a month ago. You have a month with the thing.
Mhm.
Insomnia, poor appetite. You have 2 symptoms. 3 activities, little activities, but not enjoying anything, and little activities the same thing. And difficulty. Huh?
Can't concentrate. So that's yeah. 4.
And she remember another episode a year ago. Last about 2 months before improving without treatment. She also reports several episodes, increased energy. Okay, yeah, you already have the depressive MDD, right? The persistent, because you have a year ago have the symptoms. A year ago, man, you have depressive symptoms. They remit without treatment. And increased energy in the past 2 years. You have 2 years. These episodes usually last 1 to 2 weeks, during which time she is very productive. Is that the Trevor thing?
That's that's the one for cyclothymic though. We have to see.
Entonces, ¿qué no veo aquí? Yo tengo como ahora acá. And tenemos bipolar type 1 disorder, current episode depressed, bipolar 2, cyclothymic. You think the D?
I think cyclothymic.
Okay, mira, the B. Bipolar type 2, current episode depressed. Because we have the depression. Vamos para atrás. We have the depression.
We don't have enough for hypomanic though, do we?
Okay, vamos a ver aquí. Several episodes increase energy. She also have several episodes increase energy. 1 2 weeks, 2 weeks, during which time she's very productive. She's more social, outgoing, no sleep. Yeah, you have the mania. I thought she felt energetic during the day. Friends tell her that speak more. Yeah, I don't continue reading. I buy it, but you have the mania. You have, mira, let me marcarlo. You have, hago aquí.
But because of there's at least 3 for
Esto no,
me.
esto confuse us. But that is something that tells you the severity wasn't so hard, but was 1 2 weeks. And more social and outgoing, sleepless. I don't mark that thing because more social and outgoing doesn't tell me something pathologic. Energetic during the day, friends tell that she speak more rapidly, talkative. And she more outgoing and clever. I see energetic. Energetic, ahí está. You have 3, and you only need 3 and more than a week.
Yeah, but that would say bipolar 1, right? And doesn't the answer bipolar 2?
No, because the thing that makes the thing bipolar 1 is the time frame.
I mean, I think it should be bipolar 1, but I thought I remembered the answer.
Oh,
yeah. Well, there's no impairment in social functioning.
The
impairment.
Nice, Trevor.
I mean, like, again, it says like kind of struggling with schoolwork. So, I mean, I guess depends on like how
you have the time frame, but because
is.
your function doesn't make you so chronic. That's why I don't mark the outgoing and easygoing, something like that. I don't know how many other things. How the depressive episodes associated with bipolar 2 disorder? Who's gonna do that one? Let me see the list. ¿A quién no he oído hablar? A Clarisa que se rió.
Let me see. Okay, how does the depressive episodes associated with bipolar 2 disorder differ from those associated with bipolar 1 disorder? A, they are less frequent than those associated with bipolar 1. B, they are lengthier than those associated with bipolar 1 disorder. C, they are less disabling than those associated with bipolar 1. D, they are less severe than those associated. E, they are rarely a reason for the patient to seek treatment. Let me see.
Ay, le di. Sin querer. ¿Cuál era aquí? Ahí.
So it's B because we see with bipolar 2, that's the one where it's like the mask episode that you were like saying, like the example that you used, how it's more longer. It's not just going to be whenever they have the mask on. It's going to be all the time, right?
Bueno, we know that bipolar type 2 is more but it's talking about the depressive episodes. And the depressive episodes associated with bipolar 2 seems to, you said the B. They are less frequent than those associated with bipolar type 1 disorder. That the A is not. They are less disabling than those associated with bipolar disorder. The A and C, we can rule out those two because they are not true. They are less severe than those associated with bipolar. I believe that doesn't even make sense because it's a depressive episode. And they are really a reason for the patient to seek treatment. I believe you're right, it's the B. The B, right? That is a technique when you went to your test, they do that thing, so they read the statement twice, and they came here and they said they are less frequent than they associated with bipolar 1 disorder. Less frequent. No está marcando. They are less frequent. That is not right because we know that you said is the bipolar 2 is more chronic. You will gonna be the whole year with more episodes. In the bipolar 1, you don't need the depressive episode. That is totally forced. Oye, pero no escribe. Ah, ok, acá. ¿Dónde está? Ah, se me movió. ¿Cómo lo muevo? ¿Qué quiero escribirle aquí? Ajá. Esta lo hace incorrecto. That is incorrect because they are not less frequent. They are more frequent. And the B, they are less disabling than those associated with bipolar 1 disorder. That makes that thing force too, because I don't think it's different between depression in anyone's. The difference between bipolar 1 and 2 is the manic episode. They are less severe than those associated with bipolar 1 disorder. That thing is the same thing here. Disabling or severe is the same. And they rarely the reason for the patient to seek. That is, can be true. Can be true because the patient they gonna came for the mania. But in bipolar 2, you can see the depression too. But for all them, the B is the better. And you start marking stuff and you can identify what is the best answer. I didn't know which one was the best answer. I was using that logic. Y aquí. Entonces, ajá, ¿quién es quién? Vamos a buscar el dedo prácticamente. AB.
Which of the following is more common in men with bipolar 1 disorder than in women with this disorder?
Which of the following is more common in men with bipolar 1 disorder than in women with the disorder? What do you think? More common in men. I believe that question. Como en Puerto Rico decimos que el chiste se cuenta solo. ¿Quién entendió eso? I have a lot of slangs from Puerto Rico. But the chiste se cuenta solo means the riddle reveals itself.
What'd you say?
When somebody tell you a riddle, you need to realize, you know, I tell you a riddle, it's like a guessing thing. But sometimes the riddle is so basic that the riddle reveals itself. You don't need to think, it's super easy.
I'm just gonna guess B.
We are talking about males, what they like to do.
I'm just gonna guess B. Yeah.
Yep.
I don't know, maybe I failed, but it's not difficult to think a man with bipolar, they're gonna do more alcohol. Alcohol is in depression, is in schizophrenia is tobacco. In depression is alcohol. And now we know in bipolar. And you want to read the explanation or not?
I can.
I don't know if you want, because
although bipolar 1 disorder affects men and women equally, hypomanic, mixed state, and rapid cycling symptoms are more common in women. Alcohol abuse is higher in men than in women in all cases, although it should be noted that women with bipolar disorder have a higher rate of alcohol abuse than do women in the general population. Compared with bipolar men, bipolar women are more likely to experience rapid cycling and anxiety and have higher rates of lifetime comorbid eating disorders.
Yeah, that was the last one. When I start my training in my school, and it's something maybe for you because you are starting this career, and all of you answer that you like to help. I believe Aren, that you want to help more people that you can. That makes me remember the metaphor about the kid in the boat saving starfish. You know the metaphor? I believe he left. He left, right?
No, I'm here.
You're here. You know the metaphor?
I don't know it.
He's a kid in the beach or in a boat, something, and he's saving starfish. And somebody told him, "Why you saving? You're gonna save all of them." And he said, "Doesn't matter because that one I gonna save. That I save one. I save another one." So he's counting the ones he saved instead of counting that the ones he cannot save. That makes me think when you said you want to help more people, you can, but that connect with that myth of Melampus. It's a Greek mythology about a guy, a wise guy. He has a friend, and the friend get poisoned, and it's related to healing because he lost his youth and health trying to save his friend. At the end, the friend told him that he lost his life because he was poisoned with something he cannot be cured. And the moral lesson about the Melampos methodology is we need to have this thing in mind always, because you can find out yourself self-sacrificing you, and sometimes you need to lower bars and be more fair with you. So I don't say it's bad. I believe it's the best quality a human can have, but sometimes that can drags you in the hole. So sacrificing, but you need to have it. All you have it, but you need to be careful. That's why they told us you are not in this career by accident. You are in that career because you like to help. And anybody gonna study something so long for nothing. And it's a altruism, empathy, compassion. A lot of people, they think about altruism doesn't exist. And the research said when the altruism is something that is not for your ego, it's something that you do for your satisfaction, not ego. So you can help people because your ego, or you can help people because you like it. When you like it, well, it's good. And that is the reference I use for the presentation. And that is my information. The ones I always been very accessible. I'm not so fast answering emails or whatever, but I do my best. But for me, it was a pleasure to meet you all and continue that path. I believe we need more people in this field with all these characteristics.
Okay, well, thank you so much, Dr. Melendez. We really appreciate you. So like, round of applause. We really appreciate you taking the time to teach our students about bipolar disorders. And it's amazing to see this from a clinical psychologist perspective. We haven't had a clinical psychologist present for us, I think, in recent years. So this has been really exciting. So yes, thank you so much. And I think everybody's just saying thank yous in the chat.
Okay.
But,
excuse my barrier in language, but it's something I was trying to, I don't know, it's something in Puerto Rico, we call it la mancha de plátano, but you don't know what is that. It's another slang. I have I can do a book of slangs.
yes.
But when you cook plantain, the plantain stains.
Mm-hmm.
And that stain is very difficult to get it rid of.
Mm-hmm.
And all Puerto Ricans, we said that thing when we cannot speak English fluently. We have the mancha de plátano. We cannot get rid of this accent. These memes about that thing. It's a ¿cómo se llama? Dexter Lab memes about how Puerto Ricans speak.
Yeah. It was great. And the activities were all great, and education, and also you talking about multiculturalism is super important. So we appreciate you having that in the beginning as well. And yeah, everyone, if you could just take down his information, that way if you have any questions, TEXCHIP students, please stay behind the last 20 minutes so that we can just go over a quick video, and then everyone will be free to go after that. But if you're not in TEXCHIP, you're free to go now. But thank you again, Dr. Melendez.
Okay, thank you for the opportunity, and I hope to help you in some way. Yes,
we'll reach out because we're gonna, and well, Sharon and I are about to come to the end of our TEXCHIP graduate assistantship. So I'm gonna pass your information to our new GA, so they're gonna be happy to work with you. So they'll be reaching out for future trainings as well.
Thank you. Thank you.
Thank you.
Okay.
Okay. Students, I'm going to share my screen now. Wait, let me get the video up. Perfect. Okay, I'm not going to show the full video. I might have to cut it off. There's some questions. We're not going to get to all of the questions, which is totally okay. So what I'm going to do is send y'all the link and just questions just for your own personal reflection. And maybe that can be something that we go over in supervision, you know, because sometimes we have slower days. So maybe that's something that we can reflect on in supervision if we don't, because we're not going to finish everything. All right.
Nice to see you again, Tom. How are you today? I'm okay. So I understand that since I was seeing you that while ago, that you're in hospital again. Yeah. So can you tell me a bit more about what happened before that?
Well, it was a few months ago now. Yeah, I'd done quite well for a number of years. Sort of kept it under control, really. But
Yeah, I mean, I've not seen you since your gap year, wasn't it?
yeah, so that was 4 years ago. So yeah, it was quite disappointing to go through it all again. But it sort of started at the towards the end of university. So I was doing law, and well, I was on course for a first, and I was just coming up to my my final exams, and I had a few essays and a few exams, and so I just started working really hard. I felt like right now is the real time to put the effort in and to put the work in. So I started to step a bit later, take on a bit more work. So my stress levels sort of start to increase over a while. I was drinking a lot more coffee, took a few caffeine tablets, energy drinks. A few people, well, because sort of the environment at the time was a lot of people were pushing themselves that they wouldn't normally do, and some people were taking Ritalin.
Oh, wow, okay.
Yeah, which and
Did you take any Ritalin?
yeah, because it was just like that was necessary at the time, and
how did that affect you?
Well, it sort of increased my confidence at the time. Everything that was going on, I was becoming a lot more productive. Yeah, a lot more confident. I was working harder. My brain was working faster, and so my momentum was building up and up throughout the period. Yeah, and so I was relishing it, and I was doing a lot of work. And
So what did that mean to you then to be at that time? Because it sounds like you put quite a lot of pressure on yourself. You've been doing really well at uni, and this was it. This was the time. What did it mean to you to be feeling like that, kind of more awake and more energized, maybe?
Yeah, well, for me it was my sort of time. So I'd spent 3 years. I was in control. I was doing well. It wasn't really part of my life at the time. I didn't really talk to any of my friends about it. But then I started to just sort of grow into it. And I took the opportunity to enjoy this time. And it didn't really reach its peak until after my exams. I was still functioning throughout my exams. I have since found out that I didn't get the results that I wanted to.
Why do you think that was?
Well, I thought that I was working harder than ever, but it was misjudged, I think, and so I didn't perform to the best of my ability. In like when it came to the exams, and so I didn't achieve my first time. I only got 2-1.
What else was happening for you around that time? I mean, you talked about the pressure of your exams and staying up for them. Was anything else going on for you around the same time?
Well, so it was the end of university, and that was the time where, well, as soon as that period stopped of work, then I was sort of let off the leash a bit, and yeah, I just sort of to grow even further. So I mentioned I was taking Ritalin, drinking a lot of coffee, and as soon as exams had stopped, I just substance abuse sort of took a bit more of a hold, and yeah, I just sort of grew into this person who I thought was the guy that everyone wanted to be around and to see, and so I made sure that I was just everywhere that could be seen. I was,
so this is like the gap after you finish the exams, but before the results are out. Those kind of weeks.
So we were just going out a lot, like if not every night.
You said that you were taking Ritalin and drinking a lot of coffee.
Yeah.
And using other drugs as well.
Yeah, it sort of developed into cocaine, a lot of MDMA, MCAT.
And how did they affect you?
I honestly was on cloud 9 at the time. Yeah, I was the person everyone wanted to know. In my head, I put myself at the center of the universe, and I convinced a friend of mine who develops apps that we should I had an idea to develop an app about when you go into a alcohol shop, that it will weigh up like what's the most cost effective way to get wasted.
Right.
So yeah, I mean, at the time I was spending a lot of money, a lot of my parents' savings. I'd got a credit card which I didn't tell them about. And so in this sort of role as the man about town, I was spent a lot on alcohol, drugs, clothes. I invested in this technology, and yeah, I was.
So it sounds like it began with kind of the exam pressure and putting more pressure on yourself to stay up, using kind of stimulants to keep yourself awake, and then you started to feel like you were more and more the man. You were kind of popular, you were successful. How did you respond and cope with those symptoms? What did you do once those are kind of begun?
Well, having not had to deal with my illness throughout university, and for it not being a part of that world, I didn't confront those symptoms in a way that's going to have long-term sort of stability. Well, it began with doing the work that I needed to do. That's just what I needed to do in order to achieve my goals, achieve what I want to, and then I just let it take hold, and it was all part of it. It wasn't the illness, it was me. It was just I was the master of this whole situation, and I was everything that was happening was down to my own doing.
So it sounds, you say on the one hand you didn't confront it, you kind of just let it roll. And then on the other hand, you said that you kind of took it as evidence that you were very energetic, you were powerful. This was all kind of explained about who you were.
Okay, y'all, I think that's going to be all of the time that we have to show the video because I would prioritize the questions. Of course, you're not going to get the full picture here, but let me pop up the questions really quick. Also, Sharon, if you do want to go over the rest of these in your supervision session, or if not, that's totally cool. But I have this in the drive, but I'm trying to look for my questions here. Cool. Because we're not going to get to all of them. But where's... Okay. So there was like 5 more minutes of the video, but what more information would y'all like to know before you even think about diagnosing this client?
I mean, I guess I would want to know what his kind of like mood swings or kind of like mood periods were like, before kind of using a lot of substances.
Okay, we want to know that. So we're thinking that the substances have a big effect there for sure. See what that's like.
Yeah.
Also, let me see the medication that they were referring to, Ritalin. That's also used to treat ADHD. I would probably want to know if that's diagnosed to client too. So, because I know I had to look it up. So
I don't think it was because like from what they were talking about in the video, it's like everybody was taking it around like exam time. So it sounded like he got it from his peers.
yeah. Thank you, Trevor. What else would we like to know?
More about the substance use, like
Mhm.
the frequency and how much he was using and how long that's been going on exactly.
Yeah.
I guess like, he mentioned kind of having those thoughts of kind of like grandiosity, him being at kind of like the center of the universe. So I guess like what his thoughts are now, if he's like come back down, if he's like in a depressive episode now, I guess, how's he think about himself now?
Anybody else?
I'd like to know more about the severity of like his symptoms and like his thoughts on how much they're impacting his life. And then seeing if we can piece together any patterns that there might be, just so that I can get a slightly bigger picture. I know they were on the track of doing that. I just wanted to continue doing that.
Yeah, for sure. Okay, awesome. And in the chat, Jessica said exploring what the man was like, quote unquote, and better understanding a family history of mental health. Yeah, because it was kind of like him characterizing that part of him as a character rather than like himself. So I would definitely want to know that as well. All right. So given what little information that we have just from this one recording, what would be your initial thought for diagnosis? And the sub question to that are maybe what comorbidities would you be looking into? Or differential too, so both.
Maybe if we got more information about the substance use, there could be a comorbidity or a differential diagnosis of substance use disorder.
Mhm. Yeah, for sure. There was a lot of talk about substance use. And because this is a bipolar disorders video, I'm wondering if we're leaning like more towards type 1, type 2, and any other specifiers.
I think maybe 2.
Tell me more.
Well, again, because like the substances are involved, like we don't know. And yes, he didn't do good on his exams, but we don't know if that's like due to like the symptoms of like if that was a manic episode. But yeah, he had mentioned, like the spending stuff, that checks the box there. Increased energy, like the reduced amount of sleep, that checks some boxes there. Just kind of the grandiosity, like inflated self-esteem, that checks those boxes. But
And you
yeah, I
said
guess
type 2.
what's up?
And you said type 2, right?
Yes. Yeah, but I would say like the main thing is like whether or not that's what negatively impacted his school performance.
Okay. Yeah. What about the rest of us? Do we agree? Do we not agree? What are your guys' opinions of type 1 or type 2?
I agree. I think Trevor made a really strong case.
Okay.
Like, I'll say something. I thought it was interesting when our speaker was talking to us about assessments, and I kind of had this like aha moment, like, oh yeah, that's right. We have assessments to give. We can, if that can help us more zone in more on a diagnosis instead of like, I'm not trying to judge myself, but trusting my own instinct at this time. But I feel like if we have assessments to assess that, like we need to utilize them if possible, if available, but that's what I was thinking about that. But diagnosis, I'm unsure.
Yeah. I would say we definitely need more for a diagnosis, but I was even wondering about like how manic the episode was, because when he was referring to himself as the man, and like the spending and just the grandiosity, I was thinking like, okay, we might be leaning towards type 1, but if there's the depressive, so we definitely don't have enough information to categorize it as either or. Like me personally was leaning towards type 1, but again, it's we need to get further questions. We need to do some more probing. We need to have an integrated mindset as well. That was one of my questions, which we're not going to go over because we have 2 minutes. And so I want y'all to start thinking about like, what else would you want to know? Who would you get involved in the treatment? So, would we be referring them to psychiatrists for that official diagnosis? Is medication something that might be feasible for client? Okay, so all of these questions, what I'm going to do is I have another document with the video on it and these questions. So especially if y'all need some more hours and could use some indirect hours, watch it again, try to like look at the questions, think more into it. Me personally, I do want to follow up, especially if we're having a slower supervision session. I'm going to bring this video up and see like what y'all's opinion is. Because yeah, we have 1 more minute and it's Saturday, so I'm not going to try to keep y'all any longer. But anybody have any questions? Sharon, do you have anything to say before we go?
No, not really. I think we're all pretty like good at this point. Does anyone else have any other question before we go? It was a lot of information and it was like a lot that we got to talk about with Dr. Melendez and right now. So thank you all for being interactive with him, and you know, like participating, showing up, although you all need to be here, but you know. Yeah, well, we can continue talking about this in our supervision group as well tomorrow. If that's something they would like, maybe we can even finish watching the video in session. But yeah, other than that, y'all free to go. We'll be seeing you around, okay? Email us.
Enjoy your weekend. Thank y'all.
Bye.